looks like everyone's here. I would like to introduce Joy Bancroft, and she's our new representative. Hi, welcome. If any questions, please feel free. I'll always ask questions. Okay. So right now we'll go to public. Opening remarks, agenda review, and Gallagher update. Mr. Collins.
Hello, everybody.
Okay, Madam Chair, go. All right. So, Madam Chair, members of the trust, again, for the record, my name is Aaron Collins. I'm the area president with Gallagher. I've been a consultant on the trust since I think grade school. Just a housekeeping item for all of the vendors online and in person is we have a ton of material to cover today. We've allocated time in the working agenda for people. Please stick to the times. If when you start getting close, if it looks like you're not going to make it, we're going to warn you. You got 2 minutes, and we're going to keep going. So please make sure to give the information that you need to give, and then keep moving so the trust can get it done today on time. I'm going to start off, Madam Chair, with a quick update. You might recall. Does it go up? There we go. That my company was formerly Aaron Collins and Associates merged or sold actually to Gallagher in September of 20. At that time, our basic approach, everybody was, hey, we just want to reassure you nothing's going to change. I know that typically is seen as one of those things that's kind of like the checks in the mail, but I did want to give you an update on where we are in the process because we're pretty close to completing it. So the sale of the company was effective on September 1st of 2020. That whole first year was kind of a blur. When you go from a company that was started in Kingman, grew to the largest in its space in Arizona, but then you go to join a company that is now number 3 globally. There's a lot going from mom and pop to all of that corporate stuff. And frankly, it has been outstanding. So just to run through that real quickly, we had an introductory period that first part of the year, just getting used to all their practices, all the training, the corporate stuff. Who you're going to call is kind of a Ghostbusters thing, but the reality is there's just so many more resources that come to the table. So in that first year, we transitioned the IT, almost all of the IT. You'll see later we're completing that. Payroll, benefits, moved our employees over. All of the expenses and whatnot went over in that first year. And then last year was really the big work. So we completed all the financial integration, all of the HR. When I say HR, it's everything from payroll to training. And we're doing all this in the middle of COVID, which you can imagine just adds different wrinkles with technology. Implementing what Gallagher knows as business operating standards and systems. We'll see that with Tyler when we go back through contracting processes this year, moving from again, the small operation to the global one with all the global standards for different financial reporting and accountability. Still going through the IT integration. Have I mentioned IT integration, right? Just continue doing that, and then compliance. And then in the coming year, we'll finish that IT integration. The big thing that we're doing right now is called Document Management System, which is moving our records over onto Gallagher. And then continuing to learn how it works. Frankly, most of that you're probably saying, why is he telling me that? And that's my point. All of this has happened in the background without any disruption to services. So what we said to everybody at the beginning is, hey, look, it's going to hit us in the back end. We're going to be doing all this stuff. But I'm confident that if you speak with anyone, they'll agree that that has not led to any kind of service disruptions. This one looks a little bit like a commercial, but one of the other things was, and it pains me to say this, I created the company here in Kingman back in 1992, but one of the realities you deal with is that in the continuing growth and complexity with federal and state involvement, is you just can't keep up anymore. And this just shows you the primary practices on Gallagher's side. This is the primary ones. There's a dozen different areas, each one with specialty. The significance to you is not the commercial, but it's that when we run into an issue, we just reach out, get a collegial practice, pick up the phone for everything from prescription drugs to actuarial support and whole different sets of areas. One of them you'll have here today. We've got some folks that are beyond from the voluntary benefits side, but then you can see again executive recruiting, retirement planning, just a ton of stuff. And this is just additional arrows in the quiver that will enable us to continue to provide services for the county. So, Madam Chair, long story short, it's been a really busy couple of years, but it's been going very well, and I'd be happy to answer any questions on that before I turn it over to move on to Maritime.
Any questions?
Okay. Okay, I'm going to get out of the way and have Maritime come up and start with their presentation. Okay, so Tyler, I think you're going to pull this one up for them.
Nope.
Here we go. It's moving.
IT? Oh.
That's the right one.
Hey, Tyler, I think that's the wrong one. Hang on. I think it's this one.
That's supposed to be coming on mine, is it?
Not sure, frankly. Let's see.
No. You just add it on at the end?
Yeah, it's just the
No.
going. Here we go.
Okay. Number 8.
Yep. And it should go. Should just hit page down, page up.
Madam Chair? Sorry about that. My name is Leslie Hagan, and I'm from Maritime Health. I am the client director with Maritime Health, and I've been there going on 9 years, but I've been doing healthcare for over 35 years, and I'm happy to be here and to go over a little bit about how Mohave County's benefit plan is running. Starting with our executive summary, your membership has gone up 1.4% in members since last year. And with that change in membership, you would usually see an increase in claims, which we did see an increase in claims, yet the per member per month cost went down about 2.7% to $398 per member per month, which is in the middle of the top, with $321 for the medical and $77 with the pharmacy. If you go to the right, cost share increased from prior period about 0.8%, not much from the prior period. And we usually have been seeing that go down with COVID because COVID claims have been paid at 100%. So we usually will see that going down, but y'all's went up just a slight bit. And our block of business is running about 14.5% in the cost share for employees. If you go down to the bottom left corner, we looked at your high-cost claimants, anyone hitting over $50,000 in high-cost claimants, and that representation is 35% of the current period. And mainly it was from employees. You'll see the employees, there was 20 employees that hit over $50,000 at $2.43 million in claims. So that's the majority of your high-cost claimants is coming from those 20. But then you had 10 spouses that hit almost $1 million and 3 dependent children. If we move over to medical, go past medical trends and look at the last one is our average discount, medical discount, and you'll see that those that seeing the Aetna providers, their increased discount went up to 61.3%, which is almost 3% from last year. So that's always a good thing to see that they're seeing member providers that their discount is higher. Going to the next slide. I like to look at the right corner on this slide where it talks about the claimants, because the majority, you want to see the majority of your membership $10,000 or under, and you'll see that 1,886 of your members are under the 10,000 threshold. You still have 13 members which are hitting over $100,000, and 20 that fall between the 50 and the 100,000, and 202. But the majority of your membership still is in the under 10,000 threshold. Let's see. Let me go back. So if you look across the top diagnostics category is factors influencing health. And this category is a broad category that they added, and it includes chemotherapy, but it also includes preventative prescriptions, preventative visits, and your preventative visits in the larger deck that you have with all the drill downs. Your preventative visits have gone up. Your PCP visits have gone up. So you still have 2 members that are high-cost claimants that have chemotherapy treatment, and that is in that top diagnosis as well. But overall, your claims have gone down from the prior year, which is good, but you still have a couple of people that are still keeping those costs up. Your musculoskeletal has gone down, which is a good thing. We still like to watch it because most of the time it is one of the top 3 diagnosis categories, and that can lead to large claimants, can lead to knee replacements, hip replacements, so we do like to watch the musculoskeletal one. And then codes for special purposes, that went up, and that's your COVID. So your COVID claims did go up from last year to this year, probably closer to about $2.8 million in COVID claims. But the majority of your costs went to that, and then to the factors influencing health. Inpatient trends, your inpatient claims went down. Your highest cost was in your outpatient trends, which we like to see. Outpatient visits, people seeing professional, your doctors. We like to see the outpatient professional trends go up more than the inpatient trends. I wanted to just talk. Let me go to the next page. Sorry. So this is the slide, it's observations and recommendations that we're seeing. So like I mentioned, we see the membership is up slightly. Y'all probably know that. Your diagnosis, top diagnosis is those 2 people seeing chemotherapy and the COVID claims that are hitting at almost 3 million. And then you have 3 frequent utilizers of the ER that have more than 5 visits. And if you ever want to drill down, I do have a drill down slides in that big deck on that. You can, sometimes people want to see, where are they going for those visits. Some of the insights is emergency usage has increased while urgent care decreased. And I looked at your Teledoc usage, and that hasn't increased as a lot. A lot of times the urgent care will go down, but we'll see the Teledoc increase. People are feeling more comfortable doing the Teledoc, but I didn't see that. So one of the suggestions might be to increase your employee communication campaigns around Teledoc, urgent cares, and ERs, and what they have available to them. 7 members utilize the Teledoc mental health, which is good because that is something we're seeing. They call it the COVID, hangover, but it's like people trying to adjust to being home, people trying to adjust to this new, having to teach their kids at home. So we're seeing a lot of mental health coming up from that. So that's a good thing. Maybe add that to your employee campaign. All 7 were on the EPO plan, which constitutes 80% of your population. Now, we did have a small amount of people that moved from your EPO plan to the high deductible plan, so that's good. You had a little bit of steerage, but not a lot. You still have more people in the EPO plan, the richer plan. And some of the proposed recommendations that I'm saying is increase the out-of-pocket maximum on the high deductible plan, maybe to $4,000. So if they meet their $3,000 deductible, there's a little more cost share in there between the deductible and getting treatment after that. Do the employee campaign like I mentioned earlier. And then looking at increasing the copay on the ER from $125 to $250. Typically we see $250 to $300 for an ER copay. I have some clients that have it at $500, but it's just something to think about. Maybe not so high, but just something to look at. So I know I talked kind of fast. That's who I am. Do you have any questions for me?
Any questions? I have a couple of questions.
So you said that office visits, now because of COVID, people weren't there, or outpatient or procedures last year, a lot of them were being put off because of COVID. Was that reflected in the numbers?
Well, what we're seeing is we're expecting trend to be about 7% or 6.5%. We're expecting people to this year, the third year, typically it's the third year of a pandemic that we see it leveling off. Talking to our medical director at CVS, it usually takes 3 years. So they're anticipating people for the last 2 years will start getting procedures done, but at the same time, they're anticipating that people are more comfortable with televisits. They're more comfortable talking to their doctor telephonically, and so those people will continue to use those lower cost options in 22.
But I understand that not telemedicine, but when you see a regular doctor telephonically, they get to still bill at their regular rate. That's right.
Right, they still get to bill at the regular rate. That would be.
What kind of savings is it, except that you don't get to see your doctor face to face?
They would still bill at the regular rate, but the time might be different. So the office visit codes could be for like maybe only half an hour instead of an hour because you're not in the office sitting there visiting with her as much. It could be lower just based on the fact that they're billing for a shorter amount of time.
So you've seen that?
Yes, I have seen that.
Reflected. And you talked about mental health and people asking for help for drug addiction. Have we seen an increase in that?
I can look for that slide. I don't know that answer right off, madam. I can look at that.
And one more sort of just personal question. You said that usually during a pandemic we see in when was the last time we had a pandemic that we have that historical knowledge?
That would probably be the Asian flu, which was way back when, but they've had a couple. But we are seeing, across my book of business, I am seeing mental health increase, especially substance abuse increase.
So yeah, we're seeing that totally, and then the drugs are hardest. So I'm sure in the next few years we're going to see a lot of that. So thank you. Any other questions? Yes.
I have a question. You have 2 recommendations that would affect employees, which is increasing their copay. What's the basis for your recommendations for increasing of copays?
So increasing the copay for the emergency room is to just kind of use steerage. Like if people are really sick and they're having chest pain, they're going to call 911, they're going to go there. But sometimes if you maybe you're having severe pain, you have a urinary tract infection, or you have a sinus infection you didn't call your doctor about, those can be treated at an urgent care or call Teledoc. So increasing an ER copay just steers people to lower cost options. And the out-of-pocket on the high deductible, the same thing. It just helps people share in the cost. It's just a cost share option. In other words, when I was at the earlier slide where I said your cost share was lower, the cost share didn't go down, it went up. So that's just an option. You don't have to do that, but when people meet their $3,000 deductible, they're more apt to go, everything's paid at 100%. So we see that if everything's paid at 100%, people use it more than if they have to share 20% of it.
Have you compared those copays with other plans? Are we in line with them, or we are actually have a low copay, that's why you're increasing it, because you're comparing it to other plans maybe?
The ER copay is lower than most of the plans I have, yes. The $125 is lower. I don't have any high deductible health plan across our block of business, not very many anyway, that have the same out-of-pocket deductible as the out-of-pocket. Most of our high deductible health plans have a cost share option where they have a deductible and an out-of-pocket that's different. So there is continued cost share in the high deductible plans. And remember, on the high deductible health plans, all the wellness is covered at 100%. So all the wellness benefits on a high deductible, whether it's a colonoscopy, a breast exam, or anything like that, that's all 100%. The only time that deductible comes into play is for any illness that they have to go to the doctor for.
Okay.
All right. Did I answer your questions? Yes? Okay. You had a question?
Yeah, I have a question also. Can you tell me what percentage of our employees on the high deductible plan reached that 3,000?
I don't have that. I don't have that information with me. We can pull a report and get that for you. And I can send it out to you guys so you can have that.
Thanks.
All right.
Anyone else? Okay, thank you.
Thank you very much, and I'll get that report out to you.
We're on number, so medical claims, is this the wellness program review?
That's correct.
Wellness program review.
Good morning, Madam Chair, trustees. Hope you're all doing well. So what I'll be doing, I'll introduce myself quickly since there are some new faces. My name is Missy Jensen. I'm with Gallagher, and I'm the well-being consultant that works with the HR team here with Mohave County. And so what I'll be doing is walking through a quick, very high-level review to stay in line with the time allotment and make sure I don't get the hook from Aaron. And then do a very brief proposal introduction. I do have a vendor here who will be presenting later today for you, and they'll be going into greater detail on an MSK or musculoskeletal disorder solution for your consideration. So I'm going to be sticking with the executive summary slide. So we'll just be walking through at a high level, again, preventive screenings and services and what those medical claims or what the impact is against the medical claims, looking at Walker Tracker and then Lavongo. So this is a high level review of that program. So as far as preventive screenings and services, if you are interested in taking a deeper dive into the actual participation, I do have that in the detailed summary towards the back of the presentation. But just some things to note that we have noticed some of the screenings have had a decrease in participation. Now, some of this could be due to turnover. This also could be due to COVID. I know we use COVID a lot as an excuse, but there is obviously some of that hesitation for going to a preventive screening on site. Some members might be working from home. They might have just some of those barriers and concerns that are preventing them from going to that screening. We're not going to know the answer until we do a quick survey, a kind of a pulse check on that. So we'll be working with HR to kind of talk through what are some of those things that are preventing members from going, and then walking through some opportunities to help increase engagement. Some things when bringing it to the committee, we discussed inter-office mailing the flyers for the screenings, making sure we have adequate notice to members, and then also doing some direct mailers, postcards and things like that to make sure that they're aware that these screenings are coming up and happening, and help encourage also having spouses participate in those screenings. Other opportunities included short videos that we thought might help engage some other members. So we're working with the committee to come up with some options and see if we might be able to help increase that engagement, and then also finding out what are those barriers specifically that are preventing members from going. And preventive screenings, just to kind of bring it back, are really focused on not just neoplasms or identifying cancers in their early stages, but it's also to help identify risks for heart disease, diabetes, and things like that. So this is really not enough information on that slide. I should have added the circulatory disorders along with the endocrine, nutrition, and metabolic. But that's the goal of these screenings, is to catch these things in their early stages, so we actually have an opportunity to get ahead of them and address them early, so that we're reducing some of the costs against the trust in the future. As far as Walker Tracker, we implemented this physical activity platform a couple years ago. We administer 3 to 4 challenges each year. In general, from looking at inception through today, or actually through the end of December, we've seen a general decline in the average step count. But every single challenge that does get implemented, we see the average increase. And so those challenges are helping to, we can assume, help motivate members to engage and step up, especially with the team challenges. That's really where we see the greatest engagement and the greatest increase in that step average. As far as looking at what does that average step count mean? So the CDC has guidelines to get approximately 150 moderate activity minutes in cardiovascular exercise each week. And so that equates to around 5,000 steps on average per person. And so seeing that we have, I want to say, between 6,200 and 6,500 steps for each member on average, they're actually exceeding it. So they are getting those health benefits for those who are enrolled. We are seeing those health benefits, and that's associated with, again, reducing risks towards heart disease, diabetes, and managing weight. So I'd say it's a positive program, and it's certainly been an impact on members engaging. As far as the Lavongo whole person solution, I was a little surprised with some of the participation, and I was really excited as well. So it was kind of a mixed bag. So as far as the diabetes management solution of Lavongo, we have 68 members enrolled as of the last report that was received. And when comparing this against the anti-diabetic medication, which I think I have that on a future slide, we have almost 50% engaged. So of those that are taking an anti-diabetic medication, we have about 50% of those people actually enrolling and participating in Lavongo, which is awesome. We usually only see about 20 to 30%. So seeing that you have 50% is very exciting to me. And as far as the cardiovascular solution, that's where I was a little disappointed. I was a little shocked that we only had 5 members enrolled in that specific solution. So that's mostly focused on the blood pressure. And we have I have to double check, but we have over 250 members who are taking a medication to help treat blood pressure. So that was really surprising to me. The pre-diabetes solution, we have 40 enrolled in that program. I think it's pretty good, but I can definitely see us increasing that engagement. As far as kind of the outcomes, we've seen a reduction in hemoglobin A1C of those members that are enrolled in that diabetes. What that translates to is better glucose control, reduction of risks for comorbidities or diabetes-related complications, so amputations and the like. 86% of members maintained or improved blood pressure. Again, we don't have that many enrolled, but Lavongo will be speaking on that after, and they'll go into greater detail on some of those programs. And then 68.8% of members have actually lost weight. So if they're enrolled in a weight management component, they do have a reduction in weight. 36% have actually gotten 5% or greater weight loss. What that translates to is reduction again in heart disease risks and diabetes. Usually it's a 5 to 7% is seen with those improved outcomes and reduction of risks. And then overall, members are enjoying the program with a net promoter score of 58. What that is on a scale of it's negative 100 to a positive 100. And it's basically the likelihood that someone's going to recommend a program to others. So they like the program, which is positive. That's great news to see. I'm happy to answer any questions on this slide, or I will continue to move forward.
Any questions? Okay, continue.
Excellent. All right.
Okay, Verlyn has a question. Please. That's okay.
Do we know the number or the percentage of employees that are participating in each of these?
I would have to double check. As far as the diabetes solution, because I'm comparing it against the known population that has an anti-diabetic medication. So I know that we have 49% enrolled in that. I did not do it further for the cardiovascular solution. And then the assumption would be on the pre-diabetes based on how many would be at likelihood of being at risk for that. So I can certainly go back and get those percentages for you as a follow-up item.
And how do we get the other 51% involved?
I don't know if we're going to get 100%. That would be fantastic, for sure. But I think there are some opportunities for incentive strategies. One of our county groups that we work with actually applies a cost share waiver for diabetic medications and supplies. And so engaging in that program in an ongoing basis, not just signing up, but actually utilizing the meter, they do receive that additional incentive. Obviously, that's a cost to the trust. And so we wouldn't want to do that today to figure out doing that for July 1. We would want to make sure that you guys are making an informed decision if you're interested in doing that. But we've seen, Aaron, 65% engagement, or I think it was 65. So another 15% added for that cost share waiver. This is fantastic, though. I would love to see 100%, but I don't know. I don't know if we will.
On that line, staff, do we put out anything to the employees telling them about the success of the people who have signed up for it? Like, I don't know if we could just, customize it to just the people who would need it, but, these successes should go out there. Do we do that to the employees?
I'm going to say I can answer that. We don't normally send out, here's our numbers, here what we have right now. We just do a lot of the encouragement for signing up.
Maybe you should.
We definitely can look into that.
Just, don't have to get in, really into personal things. Just these numbers, these percentages are really good. Your coworkers are seeing this kind of success. I think would go a long way.
I agree. Yes, ma'am.
Okay, thanks.
And another thing we can try to do, like you were mentioning, is to customize those materials to include that success information. And something that I've observed with the marketing materials provided by Lavongo is that I think they're really heavy focused on the diabetes portion. And so that might be why some members are not signing up, because they're not aware completely of all the options available. So I'll work with Leanne and make sure that we get some updated marketing so it is front and center.
Berlin? Okay.
Okay, wonderful.
Else?
Okay. I was told it's almost time, so I will hurry up. I get excited. I'm sorry. So one thing I wanted to bring to your attention is an opportunity to address the musculoskeletal conditions. So as Maritane had mentioned, it's number 3 right now, but when looking at the fiscal year information, it's consistently been in the top 2 medical claims spent. And just to highlight some of those conditions specifically, I pulled this from Maritane's report, so this is in line with their time frame. Some of the conditions here include acute and chronic back pain, okay, that's just disc disorders, so back issues, joint issues, and then also osteoarthritis, knee conditions. And so we have an opportunity to address the MSK, musculoskeletal disorders, through a Hinge Health program. And so it's a program that is a digital solution to help members to manage and even prevent and treat certain MSK conditions, very common. So you name it, whatever joint is there, they're able to help address the needs of that specific person. And so quickly, overview, they have 4 distinct programs: prevention, acute, chronic, and then pre and post rehab. And a member receives a welcome kit based on their program that they're enrolled in, based on their risk screener, and provided with a tablet and wearable sensors. And then exercise, a physical therapist, behavior change, health coach to help support them, and expert medical opinion as well. So I'm not going to, again, go into huge detail because Hinge Health will be here to provide you with a detailed overview. But I do want to note that they are putting 100% of their fees at risk. So if there is not an ROI of a 1.5, the county does get additional feedback or compensation back to them. The program is billed as a preventive claim, and so this would be covered 100% by the trust. And based on their enrollment in each program, they anticipated around 87,000, or actually 88,000 annually for this program. And again, I don't want to go into too much detail on it because I don't want to steal their thunder and I would not do it justice, but I'm happy to answer any questions that you might have at this time.
Anyone have any questions? Berlin?
Did you say 1/3 of the claims?
It's in the top 2 consistently.
Thank you.
Yes.
Okay.
Thank you so much.
Thank you so much.
Thank you.
All right. Up next, we have the Lavongo program review. Is that was part of what
So
you
they
did?
should be on the phone.
Yeah, hi, how's everyone doing? Can you hear me?
Can you speak up, please?
Hello, my name is Joe. Can you hear me okay?
Can everyone hear him okay? Excuse me?
You're going to need to get closer to the phone or the speaker because you're coming through kind of light.
All right, I'm as close to my Mac as I can be, and I'm talking loud. Is this
Yeah,
gonna work for
that's
the group?
good. That's good.
Okay, great. I'll keep my camera off. Otherwise, you would just see my forehead at this point, as I'm so close to the computer here. But it's a pleasure to meet you all. My name is Joe Decker. I represent Lavongo and Teledoc. If you're unfamiliar, we did a merger about 12 to 14 months ago to bring our programs together. And so what I'm hoping to do today in about 15 minutes is really add on to what Missy just shared with you all. We have some really exciting information on that front, on how the program's been doing. I also want to give you an overview of just chronic conditions to set the stage for what we're actually fighting up against. Talk about a few engagement items. You've already started to spitball a few of those, it sounds like. And then finally, follow up with a few things on Teledoc itself. I know Missy just went over a few of the key metrics, and so feel free to, raise a hand and let me know where you'd like to best direct this conversation so I can get you the information you want. But Really excited to, again, jump in here. So I'm going to get going and just let you know the state of affairs as it relates to chronic conditions and why Lavongo is a partner of yours. Multiple chronic conditions are driving significant costs for people across the United States and the world. People who are living with, let's just say, diabetes only, our annualized cost for those is about $9,000. And this cost is only continuing to grow. Right now, we have about 450 million individuals living with diabetes around the world. And by 2045, that number is going to increase to about 750 million individuals. So this problem is only increasing, and it gets conflated when multiple chronic conditions are in play. So as you can see, the trend to the right is that as you add chronic conditions, the cost just continues to skyrocket. And then the biggest thing here is the cost of inaction. So if we're not fighting diabetes, and especially prediabetes and hypertension, you're going to experience costs down the road as we see your older population, 3 out of 4 of those having at least one of these, if not more. So gonna go into the executive summary, but before I do so, Missy shared some numbers about our enrollment. I think there might have been a little miscommunication on my part to her and some of the reporting, because it's actually a lot better than what was shared. The information she shared where there was only 5 people enrolled in hypertension, it's a little bit of a semantics, but that's only 5 people who are predominantly hypertensive and use that as their main program. So we actually have 47 enrolled in hypertension, and you can see the other numbers there across the top. Some really, really healthy enrollment numbers that we've seen. And what this means is that there's actually a population that are working on those multiple conditions. And so the stats that Missy shared earlier, 5 of those individuals would have gone through the questionnaire that we present the users at the beginning of our experience with them. And from there, they're really put into a category. Are they diabetic? Are they pre-diabetic? Are they hypertensive? And that becomes their quote unquote anchor program, the one that we believe they need to focus on the most. Now, just because someone is maybe hypertensive, it doesn't mean that they're not also dealing with diabetes or pre-diabetes or anything else. And so there is kind of a cross-pollination for some of those numbers. The good thing, again, really seeing strong numbers here with some high activation percentages, meaning those who started actually got involved and followed through with the program for at least a month. So you're seeing some really high utilization rates, which is great on all these chronic conditions, but also behavioral health component, which I think we were talking about earlier. This COVID hangover, it's really impacting everything. And so focusing on the whole person has been huge for us. And we're seeing the stats that back up how impactful this has been. The first thing is the member enrollment and satisfaction. 58 on that NPS that Misty shared. This is huge, especially for a public sector group like yourself, for a vendor like ours. We typically see in the 50 to 50 range, and so upwards of 58 is amazing. We're also seeing, as I mentioned, some only good initial utilization, but ongoing engagement. And so members are checking in with their program on average 31 times a month, which is amazing to see. And a lot of those members are having those connected devices or scales that help us track these results over time. But what does this mean? It means that we have some great clinical outcomes. So people are continuing to engage, they're loving, but we're seeing the results as well, which is great. So there's been a 0.8 reduction in A1C, which is up from previous year of 1.13. So a huge increase there, meaning that the work that your members are doing, your trustees, is really going a long way. Finally, we're also seeing the people who need it most, those who started from an uncontrolled baseline, which was about 95% of your enrolled population. They've had a huge reduction in their high blood pressure and the systolic rating, which is great. So 86% of members maintain or improve their blood pressure, and that's from the population that really needed it most. So this is amazing, and the people are also getting help along the way with some expert coaching, and then the push notifications and on-demand and scheduled meetings that set up with our coaches to make sure that they're working on this effectively. Here's a quick snapshot again of those averages, and I'll do a little comparison to our book of business. Overall, this is a little below where our book of business would be, but public sector group, this is really healthy. So for device monitoring, we typically see 70% public sector group like yours. We also see the expert coaching being below 5%. So we're really excited to see not only the expert coaching, but the digital coaching being really healthy. The digital health coaching is something that has skyrocketed for your population since previous years. So we're really excited to see that people are not only working on this, but trying to find the best way possible to get better. So before I go any further into a little bit about just Teledoc as a whole, the group again that bought Lavongo and how we're going to continue to partner with you, I did want to share a few promotional items. And before I do that, I will pause and see if there's any questions. I don't really have a good line of sight to the board of trustees there.
Okay, thank you. Are there any questions from the trustees? No? Oh, you got one for Lynn?
Is the 8% expert coaching, is that 8% of those involved in the program or of all employees?
Great question. That's 8% of those involved in the program, not of all employees. So the biggest thing we'll need to fight there is getting more people in. Like you were saying right before with Missy, where are those 51 other % of people? Why haven't they engaged yet? And that's kind of my next line of thought here too, and some things I'd like to share. But does that answer your question, or do you have any other thoughts on that?
That did answer it. Thanks.
Okay, you can continue.
Great. The thing that Missy brought up is spot on as it relates to driving messaging and awareness. We want to start with education and getting information out there that this is not just a diabetes program, but really that whole person. Things like pre-diabetes, hypertension, and what that might look like and the impacts that it can have. And so we've put together a few materials for your population that we'd like to start circulating. I'm trying to share those right now, and I'm hoping you can track along. But really simple to do the registration for Mohave County. And we're sharing that information right up front with people, especially that there's no cost to them, and there's a lot of different programs that are available to them. Finally, we want to let them know as well that this is a lifestyle change. And so how can we help and support those members on that education front? We want to get the information out, not just on the programs themselves, but some of those underlying habits that we can work in tandem with the wellness program to promote, as we know that this isn't just something you can check a couple times a month and it will get better. It's something that people need to work on daily. And so we have some information and materials here as well that we would love to work on. The other thing that I was thinking would be great, and it's something was brought up by the board, is those member success stories. Those are huge and going out to the population, that 51% of people who aren't engaged. It allows us to really share a relatable story with that group of someone who's not, excuse me, from this, sorry, just got a little internet thing there. It allows us to go into a group and tell a relatable story so that they feel a bit more comfortable engaging in the program because they can see the impact it's had on someone just like them. And so we love to find those success stories, and we can start to pull from our data to find some of those parties and work with you to get that out so that your members can become more engaged. All right, I'll wrap up with a few more slides unless there's any questions. But Teledoc Health overall is a company that's trying to transform healthcare. We love partnering with you all in a multitude of different facets, but we do want to bring you forward with us as we continue to change the world of healthcare. So right now, we're working with you in a few different capacities. Of course, the chronic care solutions, but also some mental health care and some acute care items. These are things that not only are great for your member population in the sense that they can access it anywhere, anytime, but it's helping them focus on a whole person item and get a much better, clearer picture of their health. Right now as well, we're seeing a pandemic in the preventative space where people have opted out of surgery and have seen their primary care physicians. Our information tells us that 4 out of 5 working age adults actually don't have a strong relationship with their primary care physician. And that's a huge issue because 60% of members who are high cost today were not high cost 12 months ago. And that's because they've been deferring care, they've been deferring treatment, and they haven't set up a treatment plan that can catch some things like hypertension, diabetes, or being pre-diabetic. And so what we're really needing to focus on is driving people to their primary care physicians this next 2 years in order to help catch up from that COVID hangover that we've been hearing so much about. And that's where Teledoc is here to hopefully help. We have our own primary care, completely virtual, that we can offer to members at a very exciting and cost-effective way. The thing that makes us different is that we are able to create and maintain personalized care plans through our dedicated care team. So it's not just going to the doctor once a year, it's actually working with this group ongoing to create a longitudinal care plan. It's going to address the issues that come up along the way, especially after this long hibernation of care. I think I'm about at time, and so I would love to answer any last minute questions here. Otherwise, I can follow up with Misty and Amanda and the whole team. But thank you so much for having me. And again, we have to answer questions you have at this time.
Thank you. Are there any questions? I see none. Thank you so much.
Thank you. Have a great one.
Blue Cross Blue Shield of Arizona overview, discount and utilization review.
Yeah, why don't you grab the mic. Good morning, Madam Chairman and trustees. My name is Mike Greger. I'm the Commercial Sales Vice President for Blue Cross Blue Shield of Arizona. I'm responsible for all sales and service of all of our commercial business, and ultimately responsible for the performance of the MC EBT on your behalf. So thank you for having us here today. I'm joined by Rachel Martin, who's the Strategic Relationship Executive on your account and responsible for the day-to-day activities surrounding MC EBT. So good morning. I just have a couple of opening statements, then I'm going to turn it over to Rachel to talk about the strong performance of the program. We appreciate our long relationship with MC EBT, and we believe it's that collaboration that over the years that has led us to this point today. We've done a lot of things successfully. I think we provided a lot of value over the years, and we look forward to continuing that. We understand we're out to bid. We understand that, and we welcome competition. We also understand that we have put together a pretty strong proposal improving the fees. But as Rachel will demonstrate, the value that you get versus the fees that we charge far outstrip, what those fees may represent in the total cost structure. We also have plans for statewide provider expansion, which includes Mohave County. At this point, I am not at liberty to talk about the details of that. However, if we are retained, we would like to come back to the May board meeting and discuss what those plans could be specifically for Mohave County. And finally, from the legislature, I would like to just highlight SB 1161, which has actually made it through committee and is designed or set up to provide expansion to provider, to pharmacy medications. We feel that this bill will cause an extreme increase in your RX costs. Now, we know we're not the RX vendor on this, but we are in Arizona and we're all neighbors, and we just wanted to highlight that. If you look up SB 1161 on Google or some search engine, you will see a lot of dialogue on that regarding non-support. Number of the chambers around the state have taken a position in this because they just feel like it's going to be more difficult for businesses to afford this new bill. So with that, I'd like to turn it over to Rachel, and thank you for your attention.
Thanks, Mike. Good morning, everybody, and thanks for the opportunity to talk with y'all. I'm excited to go through some numbers for you. Excuse me, let me go the other way. Today we'll talk about my team and the value of the Blue Cross network. I'll get into some service enhancements, and then just briefly talk on the renewal RFP solution. I'll leave that to Gallagher and the actuary in your private sessions to make your final decisions. So I'm Rachel Martin. I have been relocated here to Arizona about 2.5 years. 2 of those years have been sucked down in COVID, so it is a pleasure to meet you all in person. You all have my business cards, and I think if I didn't leave one on your chair, I think I have a couple left, but I am happy to be here, happy to see people. Keeping a salesperson locked down is like a dog in a cage. It's really tough, but I just appreciate meeting you all today and having the opportunity to talk. Also on my team, I have Sherry Hurst, who works with me to support any on-site. So if there's opportunity for a health fair, we would love to be here. If there's opportunity to hear from the membership, we would love to be here. Blue Cross Blue Shield, I've been 26 years in 4 different states. The common theme with the Blues is that we are local, we have feet on the ground, and the communities are very important to us. So please invite us. We will be your confidant in the network component of your offering. So I want to talk about the value of our network. We know here in Mohave County that the access is tough. We know, as Mike alluded to, that we are working on expansions, and Mohave County is part of that. I will continue to provide insight to the Gallagher team as we meet quarterly to talk about what those look like, what those expansions look like. On top of that, Kingman Regional Medical Center happens to be a Blue Cross Blue Shield of Arizona client. So we are working with them currently to develop what we call site of care. So what that means to us and to you folks and the membership are for those folks that are seeking treatment for cancer. We saw in the Meritain presentation that cancer is a high driver for you folks. Any of those services where people are receiving chemotherapy or infusion, we're working with Kingman and other agencies to move them from an outpatient type setting, which we saw was your highest utilization, and my data reflects that as well, to a home setting, to a outpatient ambulatory surgery center. So those are things in the works today that is being worked on with my provider relations representatives to make sure that we can maintain the cost here in Mohave County, because it simply is unsustainable. So we know that, we're working towards that, and I just want to make sure that you all hear that from me as your representative with Blue Cross Blue Shield of Arizona. Let's talk about numbers. So Tyler, this is for you. The time period I just wanted to call out here is December 1 of 2020 through November of 21. Total claims that were billed to Blue Cross Blue Shield of Arizona was roughly $26.1 million. The total allowed, that's the contractual amount. That is the contracts that we negotiate tooth and nail to make sure that the affordability is there. So contractually, the trust paid $10.5 million. So simple math. The one minus the other equals the savings that we've provided to you throughout that 12-month period, which equates to almost 60%, 59.7. Now, 1%, because we are in bid, and I wouldn't be doing my job if I didn't show you what that 1% of value equals. So 1% of our contracts discount is roughly $261,000. So if there's a difference in network percentages, so example, if competitor B comes in at 5% less than mine, that's leaving about $1.3 million on the table that the trust would have to absorb. So I wanted to call that out. Any questions to that effect? Okay, so on this particular slide, because we do not administer the claims, we simply price the claim and send it back to Meritain for the adjudication. So they get to see all the glitz and glamour. I get to see just how many claims come in and out the door. So with that said, I wanted to share with you folks that it falls in line and suit that we have 3 different sites of service: inpatient, outpatient, professional, in our industry. And the trust is 45% of the claims that came through were outpatient setting. So what did that equate to? The discount that we provided on all of those outpatient claims was roughly 55%, and that was alone $7 million in savings for the trust. That increase, we had an increase to outpatient savings from the year past. Last year it was 6.2, this year it was 7.0. Increase to outpatient claims, and that was 44, almost 44%. Last year was 26.95, and equivalently, the discount would also increase as the outpatient settings and claims and utilization have increased. So it goes back to deferred care, and so half of that time period because of COVID, and now everyone is starting to seek care, and we're starting to see the residuals of that. Oops, let me go the other way. Oops, sorry. Trying to talk fast and stay on track. Okay, so this particular slide shows, because as long as I've been blue, you could cut me, I am blue. We always get beat up on price. You're too high, you're the Cadillac, but there's a reason for that. We bring you value. And what I mean by that is the savings is $15.6 million. The contractual amount that I alluded to in earlier slides was about $10.5 million. 1% of our discount that I referenced earlier was $264,000. And the dollars that you are paying us today, $17.75 per employee per month for that 12-month period, is $203,000. So that cost is 2% when you're looking at the total overall cost of your healthcare expenditures. And in our RFP, I've actually reduced our cost for a 5-year period to $15. And over the 5-year period, it doesn't get higher than 15.8. So $15.80. So it's nearly a $2.50 reduction to your current costs. I have been on the road for since January. You can hear it in my voice. My voice is nearly gone, but I hear you. You guys, I know that local government is tough, and again, we are very community driven, and with the help of Mike, we understand that as a blue carrier. So as such, I've reduced your fees as low as I could get them to retain your business. Okay, so I keep going the other way. I should have got the clicker. Okay, this is just a summary. So a summary that I talked about, 59.7% in discount savings for that 12-month period. 45% of those claims coming in were driven by outpatient. And you can see we received nearly 21,000 claims to price and send back to our friends at Meritain. And 84% of those claims that came in were professional. So those are your PCP visits, those are your specialist visits that are coming in the door. Just a summary from last year, if I take to the bottom left or bottom right-hand corner, we had 11% increase from billed, 6% increase to your discount, 18% savings to the trust, and 14% increase in utilization. Professional and outpatient were your top two. Inpatient claims stayed the same. We had 126 inpatient claims. It was the same as it was for the previous 12 months. So a lot of outpatient people going to see treatment again, going to see their doctors, getting that chemotherapy treatment. Now, this is the last slide where I really wanted to illustrate for you folks that through the blues and looking back for a 5-year history with us, this is demonstrating that yellow line there is the 7% of medical inflation. So with our contracts, and we know it's tough, like I mentioned earlier, we're still providing the trust savings year over year over year over year. So I'm going to leave it at that, and also just note that the reduction in the fees, I mean, it just, I feel you, and we know it's tough to manage budgets, and thank you. Yep. Final thought, Mike, go ahead.
Yes, just regarding the reduction in the fees. You know, I mentioned earlier a commitment to provider expansion here in Mohave County. One of the things that we need to do that is have membership in place to try to drive better value. And, you know, 2 million plus members, Blue Cross members around the state helps with that. But healthcare is like local, and so we have to have those members in place. So we felt like we needed to make a commitment to you so we could work with the community to continue to provide, you know, additional expansion here. So, you know, we understand we're under in RFP right now, but this is a bigger discussion. It's about making healthcare more affordable and accessible all over the state, and that's part of the rationale for our pricing decision as well. Thank you.
Thank you. Does anybody have any questions?
Can you tell me about the number of providers in our area and whether they have decreased or increased in this period? Specifically, our bigger cities, Bullhead, Kingman, Havasu.
Yep, I actually do have that data, and I will kind of, while other vendors are going through it, I will provide that data for you guys. We did do a 3-year look back, but I didn't, I don't have that top of mind, so I have it in my notes.
Thank you.
Any other questions? Yes, Roger.
When looking at the categories, inpatient, outpatient, and then professional, what's all included under professional?
Professional are your primary care physicians, so office visits. These are typically only office visits. So office visits, specialists, so your cardiologist, your endocrinologist, any of those types of providers that are coming through in a professional charge. Some of the, like home health care also comes through in a professional charge. DME comes through. Durable medical equipment comes through as a professional charge. What are some other variants? Does that help answer your question?
It does, thank you.
You're very welcome.
Any other questions? Thank you so much.
You're welcome. Thank you very much.
Okay, we're a little ahead of schedule, and we will now go to prescription drug utilization.
Hi, good morning. Let me go ahead and get our presentation ready. Okay, is the trust able to see our presentation today?
Yes, we can see it.
Okay. I don't know why this is not maximizing. Okay, my name is David Medeiros. I apologize. I am a client services exec for the trust. On the phone with me today, we also have Mindy Hollander, who is our senior manager of the clinical account executive team, and Lisa Thompson, who is a senior client services exec on my team as well.
Thanks, David. And you might want to try slideshow across the top there. Might do a full screen view for you. There you go, from the beginning.
Thank you. It was giving me trouble with that other button. All right. So for the planned year, the planned paid amount was $1.9 million, and it did have an increase of $7 million over the previous period. The planned paid member per month was $76.81. What you'll see here is that compared to the public sector book of business, that is sort of the business similar to this trust, the plan paid per member per month was actually $126, so much lower than the book of business. The generic dispensing rate for last year was at 81.1%, which did have a decrease of 3.5%. What you'll see with the generic dispensing rate decrease, though, is that the COVID vaccinations are not yet available in a generic. So the name brand of those COVID vaccines does dilute the number a little bit. Overall, compared to the public book of business, the generic dispensing rate was at 80%. So you're still a little bit higher than the book of business by comparison. The specialty percentage of the total plan paid was at 35.5%, which was an overall decrease of 9.7% compared to the prior year. And part of that too is part of the Copay Max program, which the group adopted in 2020. And the public sector book of business specialty percentage of plan paid was close to half, 48.5%. So we are doing much better than the overall public book of business. On our next slide here, this one is a little bit busy, so we won't go through the whole entire thing. Some key things I do want to call out, though, is that the utilizing members did increase into overall, but the member cost share did decrease. You'll see that at the top section on the right here. Jumping down to the bottom, though, we actually have an overall cost breakdown of what the plan paid. So in 2021, the average wholesale price of the drugs plus dispensing fee and taxes came out to $5.1 million. Of that, there is did factor in the $57,000 in the plan paid per member per month admin fee. Network discounts contributed to $2.7 million, and you'll see that as a negative here. The member paid amount was $280,000, and other payer amount paid is $106,000, and this is where our Copay Max program that I referenced before came in. And in total, the overall pharmacy benefit costs came out to $2 million, with a per member per month cost of $79.06. This next slide, what this highlights for us is mainly here in this bottom section with our little graph. The utilization overall did have an increase of 4.9%. And you'll also see that non-specialty medications did have an increase of 12.8% in total cost, but our specialty numbers are looking really good, and we did decrease the overall specialty cost by 4.1%. Here is our Copay Max slide. This is the program that I referenced a couple of times. It was a great decision to work with the prior Navitas team and Gallagher to implement this program. What you'll see here on the left side is we did have 11 total utilizing members of the program last year. Jumping to the right, you'll see that the script count, so of those 11 members, they did fill 65 prescriptions. Originally, the total cost of those prescriptions was just under $500,000 with a total plan pay of $382,000. With the copay assistance, though, those total costs actually dropped down to $104,000. Savings in total for the plan or for the trust was $100,000. To implement the program or to run the program, there is a $75 per claim fee, and that amounted to $4,875 back to Navitas. So the savings for the trust less that program fee was $95,474 for the year. Here is another option or another program that we do have for discussion today. We figured it was great timing with the trust discussing budgets. Of course, everybody is looking for ways to lower costs. Here's another program that's up for consideration today called the Rebate Gpo. What you're seeing on this slide is the value that the GPO looks to bring in total, and Navitas is always looking for ways to value and increase those total rebates. For the group, For the folks that don't know what a GPO is, it is a group purchasing organization similar to a TPA. It's Navitas has reached out to a group where we work together to increase our purchasing power and our buying power to offer increased. When we brought the GPO, we actually brought this to Aaron Collins and team back in October, I believe, maybe November. Where he told us this, you need to pump your brakes to wait. That's not how trusts work. While we appreciate the program and what it has to offer, trusts have to take that information back and vote on it in order for the program to work. So our director, Laura Francois, took that information back to our leadership, and what we had agreed upon at the time, or at this time, is for the Aaron Collins folks, including this trust, we are providing the rebates today, retroactive back to 10/1. But if the trust decides to go with the program, we actually aren't going to withhold any kind of a fee until July 1st for the new plan year. So the trust has time to deliberate and vote on whether or not it is something that they want to offer next year. So on this slide, we have our current annualized rebates. And here we took information for the first 6 months of 2021, so January through June, took the rebate numbers that we had available at the time, because our rebate information is actually 4 months in arrears, so we only had the first 6 months. We multiplied that by 2. While we know that that's not the most scientific way of doing it or the most accurate way of doing it, when we looked back at the actual rebate information that we have since gotten, we were only off by about $13,000 on the slide. So we estimated that the current annualized rebates for the trust was looking to be about $600,000. And if we implemented the GPO program based on the prescriptions that were filled at the time, it looks to bring an increased value to the trust of $96,554. And on this slide, on this slide, you'll also note that the the projected enhancement amount of $96,000 does include the 40-cent per member per month rebate admin fee that would be implemented if the program is chosen. If the program is chosen, that 40-cent per member per month rebate admin fee would actually be withheld from the rebate payment. It would not be a new line item on any invoice. So this would just be withheld from the rebate payment paid back to the trust. And then last note on this slide, if the trust does decide to adopt this program, new addendums would need to be signed. Any questions on those parts before I hand it over to Mindy Hollander?
Madam Chair, can I interrupt for a second? We're dealing with a technical issue where you can see us all madly texting back and forth and running back to the booth. If the vendors are getting a massive feedback on their end of the world, it's not coming through. They're telling us, does any of you have your mics on currently?
I've been muted. I think our team has been muted until speaking.
Was that one on? Okay, so we're going to try that to see if that kills it. David, how's it sounding now?
It sounds better. I don't hear any echo at this point.
Okay, we had one mic on up here. That was it. So, okay, apologies. Thank you very much.
Thank you.
Okay, so any questions? Okay, we're moving right along. Aaron?
All right, over to you, actually, Mindy, to wrap us up.
Great, thank you. Good morning, everyone. I'm Mindy Hollander, as David had mentioned. I am the Senior Manager, Clinical Account Executive, and I have just a few slides to go over. The first one here is the COVID-19 vaccine utilization. This shows a snapshot of the utilization during 2021. And as you can see here, it did peak in April and May, and then again in November and December. We would expect to see those peaks around those timeframes, especially towards the end of the year with boosters. The other thing I wanted to point out here is with the generic dispensing rate, which is the bottom line of the table that's on the right-hand side of the slide. And previously mentioned, the generic dispensing rate did go down to 81.1%. However, if we adjust that value based upon the dilution as a result of the COVID vaccines, it actually would be at 84.6%. So just the high number of vaccines that were processed through the pharmacy benefit in 2021 had an impact on that generic utilization rate. Next slide. This next slide goes into the top categories by plan paid. And in 2021, the anti-diabetics remained the top category, accounting for 30.8% of the overall plan spend. This is primarily due to increased utilization. You can see on the far right-hand side, the utilizing members did increase. The second category is the anti-neoplastics and adjunctive therapies. These are the cancer agents, and utilization increased slightly there as well. And then the third category is the targeted immunomodulators. These are things like the drug Humira, Otezla, specialty medications, and there was a slight decrease in the plan paid per member per month trend there. Okay, moving on to the next slide. The top drugs by plan paid. Humira was the #1 product. You can see the plan paid there was just under $182,000. The trend was actually decreased at minus 11.1%, and there was one less utilizing member. The next drug is the Ibrance, and that is an oncology medication. That remained relatively flat as far as utilizing members. The plan paid per member per month did increase slightly. And then, not going through every single drug on the list, I'll just highlight that any of the medications that you see with an asterisk next to them, those are specialty drugs. So that accounted for 5 of the medications that you see on that list. And the other primary contributor to these top drugs by plan paid are diabetic agents. So that would be your Trulicity, which is #3, Lantus, which is ranked #6, Toujeo, which is #8, and then Ozempic, which is #10. And I will conclude with Lantus did recently have a biosimilar that was released. And so effective 1/1 of 22, Lantus is no longer preferred on formulary, and the bioequivalent product is preferred. So that's a plan savings opportunity. Okay.
Thank you, Mindy. And wrapping us up, I did include a couple of different slides. We know that patients and plans are both looking for ways to save money on prescription drug costs. The first slide here, we did highlight our member portal at nevidis.com/members, where members can consider taking generic substitutes, taking advantage of 90-day fills, things like that. I also included a second slide about our Navitus mobile app, where members can download our app to compare the medication prices around them. You can actually go into our site, type in the name of the medication, and see all the different pharmacies nearby that and the cost if you were to fill at those different pharmacies. They can also access their ID cards and manage their medications through that app as well.
Okay.
And that wraps it for us. Are there any other questions?
Any questions?
Will the federal government reimburse for any of the COVID vaccines?
The COVID vaccines are being reimbursed today at $12, I believe, and that's for the plan. Mindy, do you know about any kind of reimbursement from the federal level?
Yeah, so I think they're asking about the vaccines, not the COVID test kits.
Oh, yeah, you're right.
Yeah, so for the vaccines, they are reimbursed at 100%. The pharmacies, though, are able to charge an administration fee. And so the amounts that you're seeing are that allowable reimbursement for administering by the pharmacies.
Okay. I have a question. During the year, people approach me, being the chairman of the trust, and having issues
with some of the medications. I would like to ask staff, I mean, I'm sure I just see a small percent, I hear about it. What do you guys see? And are they usually taken care of?
Madam Chair, we do have questions that come across or, you know, the telephone calls and emails of why isn't this being covered or why is this higher than what it is now? And honestly, we do refer back with the help of Marina from Meritain and working with Navitas just to verify where they are on their plan or if something that's changed. Part of it is we are reaching out also to some of the pharmacies that there has been a change that we're trying to keep up on.
Have we seen pharmacies who've dropped us the plan?
None that I'm aware of in our local area here, at least in Kingman, but I have not heard anything from Bullhead or Havasu.
Are the employees generally happy with it? Are you seeing more complaints, less complaints?
I would actually say less than what it has been the last couple of years.
Okay, and the ones that come through, you're able to rectify?
Yes.
Okay. All right.
Madam Chair?
Yes.
I can tell you also that it's not just our plan. Some of it is our pharmacies here in town. Personal experience, they thought it was too much to pay, so they canceled my order without letting me know about it. And then I had to call the Navitas people, and they said, no, the pharmacy declined it. So we have that issue when they think that the medication may be too expensive for the individual, the pharmacy cancels it.
They made that decision for you?
They made that decision, and we had to go back in and tell them.
That's pretty bold.
Yes, it was. So that does happen too, and it's not part of our plan, but that is what's going around town.
Okay. Any other questions? Roger.
Given the increase in inflation that we're seeing, is there any concern in the industry as to where prescription costs are going to go up this year?
I don't think I've seen any concern myself. I know that inflation is always a concern, and of course everything is going up, but I haven't heard anything directly, no.
Anyone else? Thank you very much. And now we will go.
Thank you.
Let's do it.
Amanda, do we have Ann on the phone?
Yes, I am here. Are we ready for the dental?
Can you speak a little louder, please? Or to the microphone more?
Are we ready for dental? Yes. Can you hear? Okay.
Ann, we still can't hear you.
Huh, interesting. I apologize for that. How about, let me turn my volume up a little bit. Maybe I got something going on.
Okay, I think you're good now. Go ahead. Just make sure you speak loudly, Ann. I know that will not be a challenge.
No, no, not at all, Aaron. Good morning, everybody. Thank you for letting me be part of the trustee meeting. I look forward to going over my presentation with you. Amanda, are you pulling it up?
Oh, you don't have it available for you? Yes, I'll pull it up on my end. Just one moment.
Okay, thank you, because I have it, but I'm not able to screen share at the moment.
Oh, yeah, absolutely.
Sorry about that. Okay, so go to the next page, please. There we go. Okay, so starting with the high plan, your executive summary, it does look a little bit different because we recently went through some enhancements to our system. So our reporting looks and features changed a little bit. Going over the high plan, it looks like 40% of your claims were focused in preventive and diagnostic. I'm seeing that your average claim payment was $160 for the past 12 months, but compared to last year, it was $167. The number of claims per member was 1.76, but when you break it out, it's per subscriber, it's 4.19. As compared to last year, it was 1.65. Subscriber was 3.91. Your cost management savings was 37%. And we'll dig a little bit further into that a couple slides down. And then the total percentage of your utilization, members with claims, was about 68%. The year before, it was about 42. And that could still be some leftover remnants from COVID, some of the dental offices, you know, people not going back to the dental office and so forth. So on the next slide, you're going to see the low plan. And it looks like, sorry, say again. Ah, are you still there? Hello?
Yeah, and we're still here. You're kind of cutting in and out.
Oh, I'm sorry. I'm sitting still, so sorry about that. Okay, so for the low plan, your percentage of claims focused in preventive and diagnostic was 47.53. Your average claim payment was 137 compared to the year before, 128. So in the low plan, your utilization did go up just a little bit. Your average number of claims was 1.20, and then per subscriber 2.22, where the previous year is 1.17, and then claims per subscriber was 2.2. Your cost management savings was about 39%, which we'll go into a little bit further down into the presentation. And the members with claim counts was about 52% compared to the last year, which was 38. So it's interesting that your claim counts went up, and then, they went up, but then so did your average claim payment. So the same thing, it is a little bit different in the high plan. Your utilization was down a little bit, where here it's going up. On the next slide, when we look at claims by coverage category, I mostly focus in the pie charts down below, so it kind of gives you an overall view of where your money is being spent, such as preventive and diagnostic, all those services that are the green, purple, and like the bluish color, orange color, are all preventive services. And if you look at the prior year, there's not a lot of change in that either. It does look to me like your implants went up a little bit, maybe 1% or so. If you look at the pie chart, they were at 1.96, and this year they're at 2.52. Going to the next slide to look at the low plan claims by coverage category. I see that if you look again towards the bottom where the pie chart is, it shows that your orthodontia implants went up a little bit, and other than that, everything's pretty much staying. Looks like it's staying on track when you compare the 2 years together. It does look like your extractions went up just a little bit. But other than that, there's nothing that's standing out that could be alarming. On the next slide, this is where we go into your cost management savings for the high plan. And if you look at the blue portion of it, that's where your PPO savings come from. So that is the PPO dentists that give you lower prices and lessens the members' out-of-pocket expense and stretches their benefit dollar a lot further. And then if you look at the non-billable procedures, like the purplish area, it shows that we saved over $60,000. Now, those are the charges that you cannot bill the patient, the member, or the plan. So those are basically strictly write-offs due to bundling or unbundling, or services being done on the same date as another service, warranty work, if you will, like if something happened to your filling and it was less than 2 years. And then you look into the eligibility verification, your coordination of benefits, When you get down to the Delta Dental Premier fee savings, that shows that there was over $11,000. And I think basically what that means is that if you were not on Delta Dental, these premier dentists would be considered out of network with any other insurance provider. They are unique to Delta Dental and they only accept the Delta Dental insurance coverage. So what's nice about Mohave County is that you do offer your employees both the PPO and Premier network. And then on the next slide, it's kind of showing you a little illustration of your plan design savings. So this is just kind of a snapshot that tells you about where you're saving your money in as far as deductibles, your plan maximum, non-covered procedures, and then your cost sharing, your co-insurance. That's the way that you have the plan designed. So the cost sharing would be people that are having a crown, they're 50% co-insurance, or they're having basic services, they're 20% co-insurance. Moving on to the next slide. This is a snapshot of your low plan, your cost management savings. And again, the PPO savings is very, very good. It looks like your non-billable procedures saved you some money. Your, I'm trying to find, I'm sorry, the Delta Dental Premier Dentist Savings, which is way down on the bottom, shows you that you did have savings there as well. So again, those are the premier dentists that you have access to, so they don't balance bill you. Moving on to the next slide. And this is your plan design savings for the low plan. It shows you your plan maximum savings. Sometimes we monitor that to make sure. I know that you never see a lot of changes in the annual maximum with dentists, with dental insurance. And it kind of seems like it's a little archaic, if you will, or in the past, but we monitor that just to make sure that plan designs, because our most common maximum is $1,500. We do have some groups that still have the old-fashioned $1,000, but you know, you go and you get maybe a root canal and a crown, and
I think we lost
Amanda.
No.
Are you still there?
You're back on.
Okay, so sorry. So we keep a close watch on plan maximum savings to make sure that you have the right amount of yearly maximum benefit available. So if we notice that there's a lot of people that are exceeding that annual maximum, we may suggest to Erin or Amanda, let's look at increasing it, see what the cost is going to be for that. But it seems to me like everything is pretty stable with this particular group as far as your annual maximums, because you do offer both the high plan and the low plan. And then the next slide is basically just the definitions and the descriptions of where your cost management savings, those pie charts, what they represent. So you can go over that. And like I said, it's a nice thing to refer back to make sure you're understanding the non-billable procedures, for example, and then the PPO and the premier dentist savings. On the next slide, this is basically your dentist. Oh, one more slide down. Sorry about that. Okay, this is your dentist selection pattern reports. So we like to keep track of this again. What I'm going to say is if you look at the top, the 3 items up on the top, the non-participating dentists, there was about 95 claims. So sometimes we find that a dentist may not participate in any insurance and people are going there, but we also find that some people tend to travel over to Mexico or to other countries to get their dental work done. It's kind of interesting because based on your location, it's not real easy access to go. We see the utilization a little bit higher with groups that are on border towns, maybe like Yuma or Nogales. So we see a higher utilization for foreign claims. But overall, if you, again, you look at the Premier Dentist savings, your claim count was 264 claims. So those 264 claims, again, would be considered out of network if you were using any other insurance. And we noticed that a lot of your people are using the PPO providers, which is great because it's also saving the plan some money too. On the next slide is a snapshot of the low plan dentist selection pattern. And basically that's the same thing again, your non-participating dentist, there was only 17 claims. Sometimes we can drill down into that if you wanted to investigate it a little bit further. I don't really see a need to do that unless it's your preference. But they also like to do it for recruiting purposes. Maybe there's a dentist in the area or that you're receiving the benefits people over at the county are receiving inquiries about certain dentists. We're happy to reach out to them and to explore the possibility of getting them contracted. Our contracting network for the Premier Dentist is now closed, so we're not adding any additional Premier Dentists, but we do add PPO dentists every day. And the next slide, I think, is just our customer service statistics. Basically, this is again a snapshot of what we're doing as far as claims processing. We have performance guarantees attached to the dental association that we're trademarked with, which is the Delta Dental Association, as well as keeping our customer service statistics up, claims processing turnaround time, and then enrollment. So a lot of the other carriers, they don't usually have a standard for processing files, doing ID card, sending them out the door, making sure that everything is up and running and happens quickly when we add somebody in the files that we do receive. And then we basically also monitor an abandonment rate for your calls to make sure we have the right amount of people taking these calls, so there is no worry about your average wait time or average speed answer. And I think there's one more slide. Oh, that's about it.
Any questions?
I apologize. Sure.
That's okay. Any questions? I have a question. You know, dental costs are astronomical, you know, no matter what you do. And what we have pays a small percentage. Is there any talk about maybe getting a super duper plan, a premier plan that you'd pay more, but it would give you higher benefits?
Yes, of course, because you are self-funded and you basically pay your own claims, we can look at any type of plan design you would like. So maybe, for instance, you would want to look at a $4,000 max or a $5,000 max. We can certainly entertain that idea and submit some claim cost projections to see. And obviously, I'm sure you would want to cost share it with the employees. So yes, they would pay a higher premium. But more importantly, I would like to dig a little bit deeper into people that are exceeding the maximum to see, or if you did a survey, for example, how many people feel that, you know, they need to get more benefits in the dental field. We can certainly explore those ideas as well.
Did you want to say something, Erin?
Yeah, Madam Chair, I was going to say, frankly, with what you see with the higher limit plans, like the $5,000 plans, frankly, for normal dental, people don't even hit it. But it's for specialty things like implants, adult orthodontia, things of that nature that what you're talking, if you were going to do a super duper plan, you know, something, that's the kind of thing we would add in that frankly, it's very expensive. But if you combine those types of benefits with a higher limit.
Right. Well, it's very expensive to have it done. And, you know, we're tend to be a little older demographic. And those are all the high things that happen when you get a little older. So is there a way we can sort of maybe do an informal survey to see if it's something that our employees would consider? Would they pay more to get better? Because I'm always shocked when I see how little.
We could also run numbers with Chris
Okay.
to do something like that. Depending what the timeline you want, we could put something together like
Okay.
that.
Is
I mean,
that
frankly,
okay
I
with
think at this point in the short notice, it would probably be more like just an informational item.
Yeah,
Because
that's
you
all
want
I'm
that
asking
back
for
there.
right now. I mean, just to put it out there, it might be, you know, a non-starter. People might not, you know, want it, say it was, you know, they're happy with the way they are. I'm just curious. Is that okay with the trust? Okay.
And then, Madam Chair, if I could, Trustee Tennell had a question for Blues on changes in the network, and Rachel has flagged me. She has texted me very nicely and said she has that number. So if you don't mind, I'd like to ask her to come up and answer the question.
Number? Which number?
Okay.
The Blue Cross number you asked for?
If there are no other questions, I can go ahead and leave.
Okay, we're cool? Rachel?
Answer that question.
Okay.
At the stat, just on line of sight. Okay. Okay, so thanks for the question, and I do have the stats for you. So I looked back at data from January 1, 2019, all the way through February 1st of 2020. So we currently have 1,792 active providers. Kingman, that represents 645 providers, or 36%. Lake Havasu, 555 providers with 31%. Bullhead City, 597 providers, or 33%. Of those active providers, 98% of them are taking new patients, 0.01 are not. And the top three, we did have 323 terminated providers through that timeline. The top three categories of terminated providers: family practice with 30 terms, anesthesiology, 27 terms, and certified nurse, registered nurse anesthetics at 22. What was interesting to me is that of these 323 providers that terminated their Blue Cross contract and these three cities, they remained blue, but just not in our quadrant. So they're still within our network, and that represents about 32%. But 68% of those 323 providers simply left the network. The top three providers that are active: family nurse practitioners, family medicine, and physician assistants. So those are all our primary doctors, primary PCPs, as we refer to them in our business. So hopefully that addresses your question, Madam. And if you have any other further questions, I'm happy to oblige.
A follow-up question to that: out of the ones that terminated, do we know how many of those were in each of the areas?
I don't. I just have the termed number as an aggregate.
Thank you.
Any other questions? Okay, thank you so much.
Thank you, Madam Chair and trustees.
Are we done with the, are we done with the dental part as well?
We are, Madam Chair, so we're moving on now to the Employee Assistance Program.
Very good.
Thank you.
Thank you. Okay. Who we have on the phone for this?
Hi, everyone. This is Tanya Barch and Alex Carter with Uprise Health. I'm just pulling
I'm sorry,
up the
can you say your
presentation
name
slide
again?
deck. Tanya Barch and
Tanya?
Alex Carter.
Can you make sure you speak into the microphone? It's a little difficult to understand you.
Let me turn up my microphone. Is that any better?
Is this better? Can everyone hear? It's not great, but I think we can hear you.
Okay, I'll speak extra loud. Did you get my name then?
Yes, we did.
Okay, great. Well, thank you for having us here today. We're here to talk about the Employee Assistance Program and what the year looked like as far as utilization and activities. But before I do that, I want to spend a quick moment just talking about the state of mental health care in Arizona in general. So the University of Arizona did a study, and we did refer to that both in the sources here and on the very last slide. So if you want to take a look at that, you're certainly welcome to do so, and I encourage you to do so. But in that study, they identified that 61% of Arizonan adults experience mental illness but do not receive treatment. They did not say why, but, likely there are access issues, lack of providers, just based on the results of that study. 40% of Arizonans live in a mental health care professional a mental health professional shortage area. That says storage and it's a typo, shortage area. So, what that means is the majority, 40% of the Arizonans don't have good access to mental health care. 10% of all Arizonans live in what they kind of determined as a large rural micropolitan area, small and isolated rural areas. So 90% is in the urban areas. And the reason that I want to point some of this out is that obviously there is a mental health shortage and mental health crisis, in my opinion, in Arizona, and finding and identifying providers is really important. We are working overtime. Our provider relations department is continually looking to see where are there areas that we can recruit additional providers. We are looking at additional resources to try to expand our network. We have included the new telehealth option, which we launched in 2020 to make sure we have additional access for members to get access to care. All of this to say that, face-to-face counseling, there's oftentimes a longer wait time, and we want to make sure that the employees and members know that there is also a telephonic option that might help them get to quicker health care, in helping resolve those short-term issues, maybe even help start the process of starting counseling and maybe moving into longer-term care because they started with EAP first, and just doing what we can to help those members get into care quicker.
Hey, Alexander, this is Aaron. Let me interrupt you. Your presentation's not showing. Do you have it pulled up in a share screen mode?
I do.
Because if we can have Amanda pull it up, and then you can do the next slide, if that works. We're not seeing it.
Okay, it says presenter mode, so I'll stop presenting. Thank you for calling that out, Aaron.
Amanda, why don't you pop it up?
Okay, great. Thanks, Amanda.
Can I just, while you're doing this, can I ask a question?
Absolutely.
So this area is something I know a little something about, between mental health and drug rehab, and we've spoken about it in years in the past. So there is a huge provider. There's not as many providers as we need. And one of the problems I think in the rural areas is that the majority of people who utilize these services are on access. And the way access reimburses is just, it does not promote competition. And providers, frankly, don't want to come because they don't get paid what they're worth. And then the other part is, in a lot of these facilities, the level of credentialing and licensing, the people they have to have on staff, again, makes it financially difficult for anyone. So when I first moved here, there were 0 drug rehab, residential rehabs in Bullhead City. Today there are 4. And so we've got the services. The problem is we don't have the providers, and they come and they go. It's a revolving door. And I do think that the insurance companies and the state is going to have to step up. And they're going to have to, finance a pool or incentivize people to come to the rural areas, because there is a need. And where our drug problems, our addiction problems are growing exponentially, fentanyl, and I don't think that we're keeping up on making sure that there's going to be enough providers to service the need. You're nodding your head, so I think you've probably, you know this already. Yeah, sure, come on down.
And I completely agree with you. And I know that just on the EAP side, we have had to increase our rates in some of those areas to get providers on network. So it's something that we're willing to do and talking to them about.
Right, okay.
Good morning, Madam Chair and trustees. Mike Greger again from Blue Cross Blue Shield. I would just like to comment on the points you just made. The mental health explosion started before the pandemic and was only accentuated through that. We have found it's amazing how the shift has taken place in all of our customer meetings. We would used to start with just a healthcare report, then it moved to prescription drugs, and now we lead virtually all of our large client meetings with the discussion regarding mental health and the capabilities surrounding that. So that has become a foundational directive, I guess, from our leadership to expand that as a local non-for-profit. And what that means is, we make money, we have to, to stay solvent in business, but we take that money and put it back in the community. We have an initiative called Mobilize AZ, and one of the three primary tenets of that is mental health awareness and development. And that means taking some of this money and pushing it back into educational resources that can help fast track and grow the number of providers here in Arizona, provide the incentives that you discussed in the rural areas. We have just developed a foundation which is taking applications from all over the state. So for agencies and organizations statewide that want to apply for funds to help with this, solutions surrounding mental health, they're out there. So just want to let you know that this is a priority for Blue Cross.
It's going to be a huge priority. In Mohave County, we are starting a program called Reach Out, and it's through the jail. And what it is, it's a jail reentry and a diversion program. So instead of putting people with mental health issues, they get triaged before they go in the jail. Then they're able to go to a separate facility where nonprofits, behavioral health, mental health agencies come in. So it takes the onus off of the jail, the taxpayers, but so there's going to be an explosion pretty much, and I hope that you're part of the conversation. Access has to be, and the blues, and if we want more, if you don't know that, they're doing, it's going to be all over the state. Yavapai County already does it. Coconino is stepping up. Pinal, it's going to be everywhere. So we're very nervous about that there's not going to be enough providers. But the good news is that with this program, the county provides the building, so providers can come and they won't have all those overhead costs, can still bill at their normal rates. So there's a lot of things that are changing and happening, and I'm hoping all for the better, but we all got to have a part of it.
To me, that sounds like a grant candidate based on the foundation that we've set up. Could you repeat the name of that program again?
It's called Reach Out. They're already doing it in Yavapai County. David Rhodes, the sheriff there, and our sheriff. We've started up the program. If you want more information, you can speak to Don Bischoff and he'll tell you about it.
So I will speak to our community team who, manage that situation. And when we identify things through meetings like this, we can proactively outreach rather than waiting for requests to come through.
Right.
So we can start the evaluation process and talk about what next steps could look like.
Okay, thank you so much. I appreciate it.
Bye-bye.
Any other questions? Okay. We're still in the EAP.
Yes, and I would just like to thank Blue Cross Blue Shield because we do work with them quite often and frequently we will review our network with their network to make sure we have a good match of providers, knowing that we have a lot of in-common customers. So we want to make sure that when members do need to go beyond the EAP and enter into the health plan, that they are in network and don't have to, have additional out-of-pocket costs. So thank you for that. Amanda, you can go ahead and advance to the next slide. Thank you. So the utilization, we're going to look at 2020 versus 2021. And so one of the things, a caveat to this is we did roll out our new reporting dashboard, and we're now reporting on additional data over this last year. And so you're going to see really big increases in that utilization. And yes, we did have increases in overall cases, but there is even additional utilization based on the additional services and programs that we are now reporting on. So that's why you're going to see those giant 100 plus increases. So in 2021, your case rate for EAP was 19%, which was compared to 7.42% in 2020.
Can you speak up, please, Tanya?
Yes.
You're kind of fading.
I'm sorry. I'll just try to keep talking louder. So in 2020, the utilization report was only reporting on more clinical cases. So face-to-face counseling, any trainings that we might have done, any critical incidents we might have responded to. And in 2021, we added to that report the work-life services, and then also digital resources. So anybody accessing the website, anybody using the chat bot, we've added those additional metrics into the report. So that's why you're going to see that really big increase from 2020. So of those cases, that translates into 29.9% services delivered within the EAP. So I'm just going to jump down a little bit in this overview here. Total cases is 246 for the year of 2021. Of the 246 cases, 383 services were delivered. So that's all of your counseling services, any work-life services, any trainings, anything like that. So it's all encompassing EAP services. So we're showing your member count of 1,280. And then the top problems, I'm going to dig down deeper in the next slide. Go ahead and advance. Thanks, Amanda. So of your total services, 47% of those were counseling services, 30% were employer services. Again, that's going to be your trainings, benefit fair attendance, critical incident response, and things of that nature. And then 18% were digital, which would be the website and the chatbot resources. The top problems for personal issues were emotional and psychological, stress and anxiety, and relationship, family, and couple counseling. And I can tell you that just looking at utilization trends over the last few months and what we're delivering, that is kind of the top trend of the top problems that we're seeing. And then the top work-related problems are workplace stress, work-life balance, and then conflict with managers. Any questions on that?
Are there any questions? So according to the total cases, that's people who reached out for either telephone consultations, work life, legal, financial referrals, management services, worksite prime, website logins was 246. I think that's a good number.
It's a great number. It's really good utilization.
It's 25% of the workforce. I know it's families and stuff, but I think that's more than I thought when we put this into play. So I'm very happy with that number. Anyone have any questions? Okay, thank you.
Okay, you bet. So of your utilizers, the highest utilizers were between the ages of 40 and 59. So you can see that here by the graph. And then the participant type, not uncommon, 93% were the employees utilizing the resource and 7% are child. We didn't see any spouse in this, but oftentimes we'll see some percentages of spouse as well. I always encourage your employees to make sure they're taking the information home and sharing it with their family members. As we all know, if there's problems in the household, it is going to oftentimes affect the performance at work. People do happen to bring things to work, even in our best, I'm all tongue-tied all of a sudden. The more we try to keep our issues at home, sometimes we just can't do that. And so we want to make sure that the household is being taken care of as well. On the next slide, I just want to kind of review some of the things and activities that we did throughout the year within the EAP. So we did launch the new real-time utilization dashboard. You just saw a little snippet of a couple pieces of that, but this gives you access directly to log in and look at utilization at any time you want. So we're happy to make sure you are set up with that. Whoever wants to have access to that, we'll make sure that's taken care of, but it is real-time utilization. So when I pull a report, anything that happened within the EAP yesterday is showing up on the report today. We also enhanced our benefits. We are now offering an online peer support group, offering 10 90-minute sessions for members to participate. And we have many different topics that range from substance abuse, depression, anxiety, parenting support, grief. We're in the process of adding some additional resources as well, which would be veterans, possibly educators, and then we have a first responder peer support group as well. And then we also added the artificial intelligence chatbot, and there has been utilization in that with Mohave County, so it's really great to see people reaching out and using all of the modalities within the EAP. We also launched our new member website in November, and then just, I think it was last week or maybe the week before, oh, here it is, February 28th, we launched the resource library that is part of that member website. So the member website is giving people access to the resources within the EAP, our Personal Advantage site, which is a resource library in itself that has lots of health and wellness articles, assessments, trainings, all sorts of things to help members get the help that they need, even from their fingertips. And then we launched that resource library, as I mentioned, that has a lot of supervisor, manager, HR tip sheets, articles, webinars, but there's also an incredible amount of member materials available as well. So if somebody logs in and they're having some challenges with grief or loss, there's extra materials out there that they can access to help give them that additional support. We've updated all of our EAP materials to make sure we have a new fresh look, especially with the rebranding of Uprise Health, which happened in October. And then Tricia had attended the 2021 Wellness Fair, had great participation in that, and was really excited to be able to visit with your employees and members face to face. So that's just a few of the resources and events that we have done within the EAP throughout the year. I think about time. Does anybody have any questions for me?
Okay, we do. Susie.
I remember we had a lot of discussion, I think last year, when we established this, or when we put this program back, and one of our discussion was availability of providers for our employees. And it seems like with the number of cases you've reported that you have sufficient, it leads me to believe that there's a sufficient provider for our area. Is that correct? To provide these services for employees?
Yes, we do have sufficient access, but we're not giving up there. We're continuing to add to the network, but we've also, as I mentioned at the very beginning, added our virtual options as well, giving members even more access. So if a member, and this happens quite often in some of the rural areas where members know the providers in that town, they don't necessarily want to go see somebody they know. And so by offering the virtual option, they're able to either log on by telephone or video and have their session delivered that way, and just increase their privacy and confidentiality.
Thank you.
You're welcome.
What is the number one request that you have on the chat bot? And also, how do people know about the online group support programs that you have?
Okay, I don't know what the number one reason for the chatbot, but primarily it's meant for emotional support, to help people maybe in between their counseling sessions, to give them that extra support in between sessions, or maybe somebody who is just suffering with some anxiety or sadness and they are embarrassed to talk to anybody about it and they don't know where to turn. It's an anonymous place to start, and the goal is to engage them, and as they are typing out their thoughts and their feelings and their concerns, in their mind they're saying it, and they're more likely to take that next step to get help and maybe reach out to the EAP for counseling services. And so that's really the goal of that, is to get them engaged to take that next step for ongoing care, whether it's through EAP, health plan, or whatnot. And then For the materials, we have flyers on each of the individual resources. We actually just finished an orientation video. It's about 6 minutes long. So we tried to make sure short enough that members and employees would actually listen to the whole video and make it easy for you to share. And that also speaks specifically to the support groups in there as well. So and I wanted to, before we end, really quickly introduce Alex Carter, who is the new account manager for Mohave County, and she will make sure that she's getting that information out to the entities to promote the EAP. And then we're also available to do any webinar, live webinars, if you have any needs for us to join department meetings or all employee staff meetings. We're happy to do that and promote the EAP in that manner as well.
Okay. If somebody calls and they, either for themselves, their family members, requests residential treatment, how do you refer them?
So if they're calling for something that's outside of the EAP, we usually refer them back to their health plan. Now, if they're in crisis, we make sure they're stabilized, but then we let them know that they need to reach back out to their health plan. We do have some accounts that we do the case management, so we can do warm handoffs, but in this case, we don't do the case management for mental health claims for Mohave County. So we would encourage them to reach out to their health plan for benefit quotes.
Okay.
And
maybe Ken can answer this then.
I'm sorry, I miss it?
So how would somebody, if somebody wants to get some kind of residential treatment for them or a family member, where do they start?
They would start with the health plan.
That's why I'm asking. I'm asking Ken Cunningham.
I'm sorry.
That's okay.
We hand out the referral cards on a regular basis. When people come into our office, they have issues. We start them off with the phone number, the direct dial.
To where? Where's the direct dial go?
To EAP.
Okay.
And then, because we don't do any of that internally, but we get calls. I think Lan gets calls, everybody in the office gets calls, and then we just refer them to the hotline number. But
what hotline number?
We have, I'll bring down business cards this afternoon, but we have business cards for the EAP that we have.
But the EAP said that they refer back to the plan. So I'm just trying to see what the process is.
When we tell employees that if they're on our medical plan, they have the two options, because we have mental health in our plan, plus we also have the EAP. So we give them options, and then we refer them to our plan or the hotline number.
But I'm talking about if they want inpatient treatment, a residential drug treatment, which I know what we added to our plan a couple of years ago.
Yeah,
Madam Chair, I see the confusion. So basically what you're saying is, hey, look, some stuff's right for EAP, some is not. So in the case where they're for inpatient, for intensive outpatient, for partial hospitalization, those three, they would be referred by the provider seeking that care through American Health Group, or the employee could initiate the contact with American Health Group, the case management, and get referrals in network.
So you just can't go. You have to get a referral. It's not like a self.
Because you'll remember, there's no coverage out of network. So the options are for inpatient and intensive, whatever, are all in network providers. You have to go to case management to make sure you're going in network, or frankly, you're on your own.
Can I get a list of that? Those, who's inpatient, who's in network, the providers when it comes to that? Because unfortunately, in so many plans, people are forced to leave our community and go out of our community, which is a shame for so many reasons, and it's usually not successful. People want to be near their families, especially if they have children. And years ago, that was the only option, but it's not the only option anymore. We have so many, and I'm just hoping that, they're pretty much on our plans.
And what's fortunate about that, Madam Chair, is we have two networks running. So in network, we have Blue Cross, right, for Arizona. But for the other 49 states, we've had Aetna. And obviously, with all the standard disclaimers about PHI, I can tell you we have facilitated out-of-state placements on an in-network basis using the Meritain network.
Okay.
Because, you know, again, I know you're very familiar with this. The difference with, particularly with alcohol, when they're detoxing off alcohol, that typically has to be done in a hospital setting because that one will kill you. You know, a lot of times with the opioids and whatnot, you'll want to die, but it won't kill you. It still may be medically supervised. So it really is, it's very...
We're going to be getting a medical detox in town too, which is something that we need, again, because people are going all over the place, and the idea is to, you know, get them, when they make the decision, get them quick, don't give them a lot of time to, you know, think and give them any excuses not to go. So I think things are going to be changing, and I just want to make sure we adapt to that.
And I can ask both to get, we can talk in between. I can ask what states you want to get, because realistically what we've been doing on the Aetna network, we've been doing Western states. Those have been the closest across our book. So we've seen some go to Washington, some go to Nevada.
Right, I want, you know, if possible, to stay in our community.
We can do that.
Yeah, okay. Thank you. I see Supervisor Bishop has walked in. You're a little late to the call to public. Is there something that you wanted to talk about? All right, okay. All right, so we are moving right along. Number 10, we have basic life, AD&D, voluntary term life, and short-term disability overview.
Yes, hi everybody, can you hear me?
Yes, we can hear you.
Okay, I'm just getting my screen up. And my name is Bill Oakes. Thank you for having me, trustees and trustee members. And I'm going to go over a few different things. And then we have to do the slideshow from the beginning too. And if I don't get it up, okay, and then we want to go over here, don't we, to do the slideshow. Bear with me a few seconds. We're almost there. Can everybody see the screen?
There's nothing showing up.
Nothing showing. Amanda, do you want to X out? Can you take over, Amanda, and start on page 210 of our PowerPoint?
She's working on it.
Okay. Sorry about this, folks. Okay, right there, Amanda. I'll tell you next slide when we're ready, but can everybody see that slide where it says agenda at the top? Okay, great. Okay, well, thank you, everyone. Bill Oakes here with a company called Oakes Inc. and representing two carriers, Securian Life for the life insurance and Madison National for the disability insurance. And that's really what we're going to talk about is your life plan and your short-term disability plan. And then at the end, if there's time, just some free value-added services that come as a thank you for doing business. Next slide, Amanda. And you can go one more. Okay, so we're going to start out with the employer-paid basic life plan. And this is for all eligible employees. And what you do for your eligible employees is you buy $50,000 of life insurance for each one. That also comes with a matching accidental death and dismemberment, as well as a line of duty benefit for your public safety officers. So what that really means and how that works is for your rank and file employees, hopefully not, but if one of them passes away, $50,000 would go to their beneficiaries. If that death was caused by an accident, let's say in a car accident, that would double because of the accidental death to $100,000 to their beneficiary. And Amanda, if you want to turn to the next slide, please. If it was one of your public safety officers, and you can see a list down there at the bottom, but if one of those folks should die in the line of duty, that benefit actually triples. So there, for that same basic life amount, that would triple to $150,000 to their beneficiaries. This is something Oakes and Securian added to our life and plans because of the rise and cause of just the pretty much attack on our men and women in blue over the years. We started with that terrible scene in Dallas that happened a few years ago with the shooting of police officers, and it happens all over the country. We just heard recently of some shootings in Phoenix, so nobody's really immune to it. So it's really a great benefit to have for your first line defenders. Any questions on the basic life at all? No? Okay. Amanda, if you want to go to the next slide. okay, employees have the $50,000 that the county buys for them. They can also buy an extra life insurance on themselves through the supplemental life plan, anywhere from 10 up to all the way up to 300,000. They can buy up to 50,000 on their spouse and up to 20,000 on each child. If they're a new hire, within the first 30 days, they can add this coverage without any health questions at all. So good, really good to get that word out to them in that first 30 days. And if one of your veteran employees has a life event, such as a marriage or birth of the child, they can also add extra life insurance without health questions, as long as they do it within 30 days of that event. Amanda, do you want to go to the next slide, please? This slide shows two things. One, the rate guarantee, how long this is good for. Both the basic life and the voluntary life or supplemental life are good until June 30th of 2025. The rates won't change. At the top, you see the rate for the basic life. It's 13 cents per thousand, 3 cents for that AD&D coverage, and then a total of 16 cents per thousand for that 50,000 that you buy for each county employee. And then below, you see the voluntary life rates. Those are what we call age banded rates. Every 5 years, the rates do go up. And the younger you are, the less you pay. And as you age, the rates go up. And that kind of coincides with their career, too, and the amount of life insurance, because when they're younger, that's when they need the life insurance the most. The kids are young, the house is not paid for. And then as they age, when they get in their 50s and 60s, they might look at starting to drop coverage because it starts getting fairly pricey up at that age. But then again, they don't need as much because the kids have grown up and the house might be closer to being paid for, et cetera. Okay. Any questions on that?
Questions? No, you can continue.
Okay. This is just 1 year of claims, and this is a 5-year rate guarantee. So we've just seen the very beginning, but it just shows that the plan is running really well. It's running at a 73% loss ratio, and that's really good in the life insurance business. So, but again, it's just 1 year of the 4-year rate guarantee, and then we'll work with the Gallagher Group in that 4th year, and then come up with the best renewal number we can. But we've got a few years to go before we have to start thinking about that. Okay, and then the next slide. One more slide. There's actually 4 free services, and these are for all eligible employees and their family members, 4 free services that Securian gives as, a thank you for doing business with us. And there's plenty of literature, so if you want to post these on your websites or even ask us for hard copy to deliver out during an open enrollment or benefit fair, we can certainly provide that to you. So just reach out to us, and there's a lot more information on these. I'm just going to cover that second one, travel assistance. And I'm actually just going to cover one of the benefits. There's like two pages of benefits that this provides. But Amanda, if you want to turn to the next slide. Anytime your employees are traveling more than 50 miles from home and run into trouble, they can reach out to this travel assistance. There's a toll-free number they call, and they provide many different services. I'm just pointing this one out because it can be a major service. And it did happen to one of Aaron and Amanda's groups, not Mohave County, but one of their other public employer groups this summer, where an employee was traveling with their spouse, and I can't remember which one passed on, but let's say the spouse died and the employee is in a different state and they're in shock and they're in grief and they don't know what to do. We provided a 1-800 number. They could reach out to a company called Red Point. They handle all the logistics and would pay for all the services to bring the remains back to the funeral home of their choice. So can you imagine that burden taken off of that family member? And that's just one of the benefits that you make available to your employees just simply because you buy the life insurance from us. Okay. Next slide, please, Amanda. And we can go one more to the short-term disability. Well, I believe it's short-term next. Yeah. So now we're starting the short-term disability. So we'll get into a different coverage. And this is, again, employer paid. So it's a nice coverage you provide your employees. You purchase short-term disability. It covers up to 60% of their weekly earnings to a maximum of $2,200 per week. The benefit starts after 30 days. So if they're out sick or injured for 30 days, that's when it would start up. And it would pay until one of three things happen. A, their doctor says they're healthy enough to go back to work. B, 150 days of illness or injury. Or C, if their long-term disability benefits kick in. Okay. Any questions? All right, next slide, Amanda. The rate for this is just a little under 23 cents per $10 of weekly coverage. And this has a 3-year rate guarantee on it, so it's good until June 30th of 2023. And then the next slide. And this plan, this is, again, how much premiums were paid in, how much claims were paid out, and it's running really well at a 41% loss ratio. So again, if renewal was today, we'd be looking at a rate hold or possibly even a rate increase. So it's running well. So really, that is my presentation for today. Oh, there's one more slide. I apologize. We're almost done. Amanda, if you can go here. Yes, thanks. This is one more free value-added service. This is from Oaks. It's called the Oaks Resource Center. And this one, rather than to the employees, it's kind of unique because it's for HR and administrative staff. And I don't know if you're using it there, but if you're not, take a look at it. We're having great success with it across the country with our public employers, but it provides all these things. The most utilized one last year was the job description builder. And you can imagine, because every public employer is searching for good employees, but they have over 1,000 different job descriptions. You can just pull the one you're looking for and plop it into your ZipRecruiter or wherever you recruit employees. But if you want to find out a little bit about this service, at the bottom, there's a short video you can click on. It's about 1.5 minutes, and it explains the benefit. And then if you're not utilizing it, just reach out to Amanda, and she'll have a contact us, and we'll provide a full-blown demo on the services it provides. And if you want to hear about it from other HRs across the country, click on the other button at the bottom, and you'll see testimonials, and they're just saying how much they love it, and it saves them lots of dollars and time. So that's my presentation for today. So any questions on either the life plan or the disability plan?
Yes, we have a question. Susie?
Okay.
You've covered the lifestyle benefits, and the packet says there's no cost to the employee. Is that correct?
That is
For
correct.
the services in the legal resources and travel assistance and so on,
Yep.
there are no
Yep.
costs to the employee if they try to avail of those services?
That is correct. So that's just a free, thank you for doing business with Securian. We're going to provide these 4 different benefits. Man, if you could previously go back about 3 or 4 slides. Right, these 4. And we can provide more details on them. This is just snippets of them. But if HR wants us to provide more details on each one of these, we'd be happy to do it, either hard copy or electronic version. But yes, all 4 of these are free to all your county employees and their family members.
Thank you.
Okay, do you have a question, Berlin? Okay, yeah, I didn't know about this. Is this new? Or is this?
No, it's when we came on board 2 years ago, these services were available, but don't feel bad that you don't know too much about them. We deal with over 610 public employers across the country and over 200,000 employees. And we always try to get the word out, but so a lot of people don't know about these, but we do want to say they're here, free to use, and I'd love to, send more information if you want it.
Okay, well, I think it should get out more, because I do think these are extra benefits that people would use and be appreciative of. So people are texting me, watching, saying, I didn't know that. So let's make sure they know that. Thank you.
Yep. Okay, thank you.
Thank you very much.
Thanks. Bye now.
Okay, bye. We still have probably another hour before we break for lunch. Does anyone need to take a break for any reason? No? Power on? Okay. Next is the identity theft overview.
Hi, I'm going to share a screen real quick. My name is Shelby Stoll. I am with Identity Force. And let's see here. Can you guys hopefully see my screen now?
Yes, we can, Shelby.
Perfect. Okay. Again, my name is Shelby. I appreciate the opportunity to chat with you guys today and really have a quick 10 slides prepared to chat with you through the identity theft protection that is provided to employees at a base level, and then the opportunity to buy up to some additional features that are industry leading and exclusive to us in the market. So each eligible employee does have our employee only coverage, which lumps in children, which we'll chat through today, but feel free to jump in with any questions as I go, or you can save them for the end, whatever is preferable. All right. So I put this slide on screen just to show you that we do have a very large international presence, both for employees who are working internationally, which, obviously might not be the case here, but also for any of your employees who happen to be traveling. It's also important to note for us that while we do have offices in these respective places, all of the data for your employees and all of the call center resolution conversations and remediation that we perform is performed in the United States. So while we think that it's fantastic to be able to call a call center and maybe book a car or a vacation through someone who is maybe not in the United States, it's important to us that all resolution when we're handling an identity theft instance is handled in the United States. All right, on screen here, you can see a number of the very large governmental agencies that we protect with the very same services that we're chatting through today. We have held a United States GSA Tier 1 designation since 1995. And that's simply alphabet soup for the fact that we are vetted and trusted by the United States government to not only protect their employees, but also respond to breaches of up to 25 million impacted individuals. So on a 2-year basis, we go through a 6-month audit, which ensures that our security practices are up to par and then some. On screen, I have our top reported instances of identity theft that are coming into our resolution center, which is staffed 24/7, 365, and is multilingual. Most people, when they think of identity theft, think of credit fraud. And while there is a fair amount of credit fraud that's out in the market impacting employees, it is not the top ranked type of crime that we see coming in. Social Security scams are number one, closely followed by unemployment fraud. And of course, with it being tax season right now, our resolution centers are seeing a drastic uptick in fraudulent tax filings as well. So this is shocking to some people, the many types of identity theft and fraud that occur that are not directly related to your credit at all. In fact, 80% of identity theft is not prevented by a credit freeze alone. So while it is important to do so, and we provide the capabilities within our mobile app and through our resolution center, there's much more to a person's identity that must be monitored in order to take a real holistic approach to that. Medical ID theft here on screen, as you can imagine, with passports, hopefully not near in the future for vaccinations or medical cards. Those can all be stored within our secure vault through the mobile application or on our desktop application. So it's a nice secure place for you to keep those documents, not having to have them in a purse or a wallet or in the car, things like that. All right. On screen here, I've got some of our heavy hitting items that we see differentiate us from the market. So when you think of your access to credit monitoring, dark web monitoring, expense reimbursement, which every employee is afforded up to $1 million in reimbursement for stolen funds out of any HSA, FSA, retirement account, bank account, savings account, et cetera. You do have a segment of your population, about 65 roughly employees who have purchased up to our premium plan, and that affords them up to a $2 million reimbursement and some additional features that you won't find anywhere else in the market today. So we recently rolled out a cyberbullying resolution and expense reimbursement. So if you think of people who have a child in school who's maybe subject to some derogatory or sexual content online, photos that are being shared, those are all things that would be covered under this reimbursement, which helps with legal expenses. It helps with tutoring, counseling, things of that nature. The other two I'll mention here briefly on screen to remain cognizant of time are our ransomware and social engineering expense reimbursements. So ransomware is as it sounds. Your device has been compromised and your documents and or files are being held for ransom. We have a $25,000 policy specifically for that instance. I know you hear of it happening to businesses and municipalities. It happens to individuals as well, unfortunately. And typically that ransom is set somewhere around $1,000 to $3,000. They don't want to toss out a very high number because they want that individual to pay it. $25,000 social engineering reimbursement, again, is a heavy hitter for us. This reimburses in the instance that you've willingly given your own information away. Likely you were tricked into doing so by someone making you think they were trustworthy, but historically speaking, that would not be reimbursable by any financial institute or by this $1 or $2 million policy. So we've addressed that need in the market as well. I want to be good on time here. I think I've just got 15 minutes. Amanda, am I okay or no?
You're right on time. Well, you're a little over, but that's okay.
I'll mention one more feature. I'll scroll through here, and then any questions I'm happy to answer. Breach IQ is what I really wanted to mention here on screen. So much like you're familiar with the term dark web monitoring, our Breach IQ is a proprietary feature that takes all of that same data that we're monitoring for every employee, and it really puts it on steroids. So it lets you know, were you subject to the T-Mobile breach, the Home Depot breach, the Target breach? And if you were, was it just your name and phone number, or was it maybe a credit card, social security number, which is a much bigger deal at that point. And then it gives you actionable steps that your employees can take to mitigate their risk on a go-forth basis, so that hopefully they're not having to take time off work or be stressed down the road with an event of identity theft if it can be prevented through our Breach IQ feature. So I will jump to this slide right here, let you know that we do have an iOS and Android compatible mobile application and desktop application for our product. But really would love to open up the floor to any questions that you might have. And I know that Amanda's got a full deck to provide as well, which lists some of our additional features.
Questions? I have one. So anyone who's listened to radio in the last year knows that the fastest growing identity theft is through your house title theft. Is that something that you are looking at?
Correct. Yep. It is on our product roadmap to be developed in Q3 of this year. We have had it on discussion boards over the past 18 months. The reason that we have not implemented it just yet is we saw a larger rise or a more impactful rise in the social engineering and ransomware features. Not to say that home credit and title monitoring is not important. It's just that some of those features, like Breach IQ, like dark web monitoring, change of address monitoring, some of our more elementary features were alerting us to that home and title fraud ahead of needing to have a feature specifically for that.
Have you seen?
It'll be forthcoming.
Have you seen that happen? Is it really fast growing?
It's not as fast growing through our statistics, and I'll provide you with some of these in follow-up as well with citations. But social engineering and ransomware and synthetic identity theft are the three that we see most quickly rising today. Synthetic identity theft is combining the components of multiple people. And so it might be someone's social, someone else's date of birth, someone else's address, and that's so that it's going undetected for most everybody aside from the person whose social security number is being utilized.
Okay.
Good question.
Okay, thank you so much.
Additional product features. We push those updates out through the mobile application. So when that launches, you will see that as well.
Okay, I think Ken Cunningham wants to say something.
Yes, Chairman, sure. I just want to say a public thank you to Sontic. They helped us through a situation where some files were lost in a vehicle. They were taken out of a vehicle for some of the county clients. And within 24 hours, they had 59 extra security put on those individuals to protect their identity theft at no cost to the county. And like says, it was a major issue for us, and they did it within 24 hours.
Fantastic. Come on, I didn't hear about it.
That's why we're here. It's an unfortunate reality that we all have to deal with.
Yeah. All right. Well, now I need to get the backstory on that one. Okay. Thank you so much.
Thank you.
Sorry. Hinge health proposal.
Apologies, Madam Chair. For whatever reason, when the master presentation was put together, it kind of jumbled up the presentation from identity theft and Hinge Health. So I'm just trying to see if I can find the first slide here.
Missy, let me see if I can't set it up on my screen.
Okay, thank you, Amanda.
Just the Hinge Health presentation. So sorry about that. I did not catch that.
Thank you. If I might, just a quick introduction. So as a reminder, I did speak very briefly about how MSK or musculoskeletal disorders have been in the top 2 claims costs for the last 2 years, and then identified some of those claims being back disorders, osteoarthritis of the knee, and other joint issues. And so we reviewed, the Wellness Committee and I reviewed a handful of proposals about 2.5 years ago. And so the committee agreed to kind of hold off on presenting some options for trustee consideration because of the expansion for Lavongo last year, which trustees moved forward with, not to bombard you with too many programs all at the same time. And so we do have Joey here to present Hinge Health, which is that digital MSK solution that trustees will have the opportunity to vote on later today. And Amanda, if you wanted to pull up the presentation whenever you're ready, and then I'll let Joey take over. Thank you.
Yes, I'm so sorry. It's pulling up right now. It's a very large presentation.
We'll go through it quick though. We'll make sure. Well, I'll just do a quick intro of myself. So thank you everyone for having me. I'm Joey Simons, like Missy said, RVP of Employer Sales representing Hinge Health today. I'm based in Phoenix, so really thankful to have be able to drive up and present our solution to you all. As Missy said, I know that MSK has been a relatively high claims cost for Mohave County over the past several years. So I want to talk about our solution and how we can address reducing those MSK claims. We're still waiting for the...
Yes, I'm so sorry. It is.
That's okay. If we want, I'm happy to start with some level setting, talk about overview. We don't necessarily need the slides to go over that, so I don't want to hold you guys up any longer. How does that sound? Yeah. Okay, perfect. Well, great. Yeah. So before we hop in, I'm going to be using the acronym MSK a lot today. I want to talk about what that means. So that stands for musculoskeletal, which are those conditions and injuries of the muscles and joints. So think about that chronic back pain, chronic knee pain, shoulder pain, very common. In fact, half of the American population suffers from some sort of MSK pain. And what we found is that if that pain is not addressed, it can send that individual down a pretty predictable path towards invasive surgeries, imaging, injections, opioids, and more. So that's what we're trying to address here, trying to meet those members to avoid those unnecessary procedures with a more conservative option of care. Now, last week I was able to meet with Missy and with Leanne Lewis to learn a little bit more about the goals and priorities of Mohave County, just to understand what those were, how we could best support those priorities. And a few of the main things that we learned, one was that MSK has consistently been a top claim spend category over the past several years. I think the data we got from Meritain showed that it made up about 14% of total annual medical spend over the past 3 years, so certainly seems to be something worth addressing. And we also learned about an increased focus on supporting mental health and overall well-being of your people. So as we talk through this today, we're really going to look to focus on those two main priorities, reducing MSK claims while supporting overall health and well-being of your people. I'll take a pause there. Did I miss, in terms of priorities, anything else I should know about from you all, or does that kind of hit it on the head in terms of what we're looking to address? Awesome. All right, so a little background on Hinge Health. We were founded back in 2015. Our two co-founders each had their own personal histories with MSK injuries. They saw some gaps in the way we were approaching MSK. They saw some gaps in physical therapy. So they decided to build a digital online solution that's going to provide members with a care team that they can meet with virtually on their own schedule from the convenience of their own home. And that's the solution that we're going to talk through today. Fast forward to 2022, we now work with over 600 employer clients. We've also had a lot of success with our public sector clients. City of Seattle, Hillsborough County, Manatee County. And I think one thing important to note here in terms of the employers that we work with is that it doesn't matter what type of job an employee is working, MSK conditions impact everyone. So it doesn't matter if you're doing physical labor, spending your time, working with your hands, spending all day on your feet, or if you're that employee that is at your desk, hunched over at your computer, this back and joint pain is extremely relevant across all different job types. Oh, look at that. All right, well, we can go skip ahead to, I think, slide 7. Yeah, this is perfect. Oh, one back, please. Awesome. Now, having worked with so many different employer groups, we've seen a lot about the challenges associated with MSK, both for that member, the individual that's dealing with that pain, as well as the plan sponsor. Now, starting with that member, right, that person that has chronic pain, we know that the effects of chronic pain, we know the toll that it can take not just on their body, but on their daily life. A lot of these individuals are juggling work, family life, any other hobbies or activities in their day-to-day. So finding the time to go see a physical therapist, access the care that they need to deal with that pain, it's tough and it's inconvenient. So we know the impact there for those individuals. Now, from the plan sponsor's perspective, we kind of touched on it, but the MSK costs continue to rise year over year. I think you've felt that at Mohave County. You've seen that in your claims report. So employers come to us looking for a way to reduce those claims and really reverse course on that trend of rising MSK costs. And we can go to the next slide here. Thank you. So digging a little bit deeper into those member challenges with receiving care, there's a lot of determinants that members face, likely determinants that your members at Mohave County are facing when they're looking to receive the care that they need for their pain. And one that I really want to point out that we're going to stress a lot today is access to care. You know, physical therapy, I mentioned, it's tough, it's inconvenient to access. We're seeing that it can take people up to 2 months to actually see that physical therapist in person. So it's kind of discouraging. They might not even make that appointment because it's 2 months away. So these are just some of the barriers that we're looking to remove for those individuals by giving them a virtual option, again, that they can do on their own time from the convenience of their own home. Next slide, please. So how do we approach these challenges? It's really through 3 key pillars for effective MSK care. The first is a complete clinical care team. So we pair that member with a complete team of physical therapists, health coaches, and orthopedic surgeons. The second pillar is through technology, which is really going to enable that member to access their care whenever and wherever they need to. And then the last is through connected care. And what I mean by that is really bridging that gap between digital and in-person care providers so that we can make sure we're intervening at the right time before that member's claims costs start to balloon. Next slide, please. All right, so yeah, this is perfect. So we're gonna talk about that first pillar, complete clinical care team. This is where we're really starting to look at our programs. Now, simply put, effective MSK care does not treat everybody the same because everyone's condition is different. Someone that has a recently sprained ankle is going to be very different from someone who's been battling chronic back pain for years. And they're going to be very different from someone who just had a knee replacement surgery. And you can't treat all of these conditions the same, which is why we have tailored and dedicated pathways to meet the needs of each individual. So, you know, starting with the prevention program, free to the entire member base for those members that want to be proactive about their health, all the way through to someone who might be having surgery, where we can support them with both pre and post rehab. And what's interesting is, as you can see here, these pathways correspond with the typical cost curve that you might see for MSK spend at an organization. So for example, where a sprained ankle, that acute situation, that actually tends to be on the lower side of the cost curve. Relatively lower cost to treat, relatively pretty straightforward to treat. And we certainly have members covered there. But as you work your way towards those chronic conditions, right, those people that are dealing with that long-term pain, that's where we would start to see that if it's not addressed, it's gonna send them down that cost curve towards those surgeries, elective procedures. So we're really focusing on meeting those members with that chronic pain so that we can reverse course and they're not going down that path, driving up claims. Any questions there so far? Excellent. All right, we can move on to the next slide. Thank you. All right, so looking at the care team here, there to support our members, starting with the physical therapist. I think we're all pretty familiar with the physical therapist and what they do. Our PTs are going to be squarely focused on that member's physical recovery. So they're there to design that care plan, design their exercise therapy for their path to recovery from pain. But what we've seen is that the biggest gap in this type of care today is actually adherence. It's actually sticking to that care plan once you know what you need to do to get healthier. And that's why we also pair that member with a board-certified health coach. And you can click next slide, please. Now these health coaches, they're to support members, they're with them step by step throughout the process. They're trained specifically in behavior change, lifestyle modification, and motivational support techniques. So while we know what exercise therapy needs to be done, there's a ton of challenges that come up in life. So we want to make sure that we have health coaches there to support those individuals around, whatever lifestyle modifications they need to make, around motivation, so that they can continue to motivate them to do their exercise therapy. Again, that's a huge gap that's in a huge gap in physical therapy today. I don't know if anyone has experience in seeing a physical therapist. You go in, it's a great session, you know the exercises you need to do. They send you home with a piece of paper, some homework to do and exercises, and a lot of times people don't stick to that plan. So these health coaches are really, really instrumental in supporting that. Next slide, please. And then the last but last but not least, are orthopedic surgeons. So if and when a member is facing that idea around surgery, it's overwhelming, it's confusing. So we have these resources available to help support them, talk through any questions they have, provide expert medical opinion to those members that are facing that idea around surgery. Next slide, please. All right, so again, that is our complete care team. Any questions there around the care team, maybe the role that they play in that member journey?
Any questions? Yes.
So when somebody signs up, do they have the same physical therapist each time and the same coach?
Absolutely, yeah. So, and we'll talk through what that process looks like, but we will make sure they have that same dedicated care team over time throughout the program. Yeah. Thank you. Okay, we can go to the next slide here. And the next slide. So we're going to walk through a bit of that member journey, so what it looks like with someone enrolling, which really starts with our recruiting and marketing strategy as that first step. Now, engagement and enrollment will start with a marketing campaign for every new client. This is where our client success team will partner with you to build out that marketing campaign with your logo, your approved language. Absolutely no cost to you here. We handle all of the heavy lifting. And this will include emails, postcards, mailers sent to the home, really anything to build that awareness among the population that they have this new benefit available to them. Now, once that member learns about the program, it's going to direct them to a custom landing page where they can learn more about what this program is and then actually start that application process. We can go to the next slide. Now, the application is going to have a clinical questionnaire. This is where we're going to gather all of that baseline information about their pain, how long they've had their pain. We'll even dig deeper into some mental health questions around depression, anxiety, surgery likelihood. All of this is going to give us a really great baseline so that we can accurately gauge their progress throughout the program. And then here you'll see they are then they'll receive an email, which is introducing them to that dedicated care team, so their dedicated physical therapist and their board certified health coach. And within this email, there's going to be a link where they can schedule that first initial video visit with their physical therapist. Next slide, please. And in that initial video visit, that PT is going to, get to know them a little bit more on a personal level. They're going to understand more about their challenges that they've faced, understand their goals for recovery. Again, really helping that member, help that physical therapist further tailor and customize the care plan for the member. Now, I brought in the kit here. Once that member is accepted, they're going to get this kit just 2 days after being accepted into the program. And this is going to have everything that they need to get started with the program. Now, there's going to be a quick start guide here, step-by-step instructions on how to get started. There's going to be wearable motion sensors, which they're going to use to guide them through their exercise therapy. And these sensors are going to give them feedback just to make sure that they're using the correct form and the correct positioning as they're going through that exercise therapy. And we'll show you what this looks like in just a moment. There's going to be some resistance bands. So these are at various levels of resistance. So as they get stronger, more confident, they can increase that challenge over time. And then last but not least, we will send them a tablet with the Hinge Health app already pre-installed and synced up to these sensors. So truly everything they need to get started, and then they're ready to go. Any questions there about the kit or that first step in the enrollment process?
Any questions?
Excellent.
None? Okay.
We can go to the next slide here. Now, typically at this point, I would do a live demo and kind of show you these sensors at work paired to the app. Unfortunately, unable to do that today, but I did go ahead and record myself going through the program so I could show you some screenshots of what it looks like. So you'll see that here. And this is really that first step. You'll see that I'm wearing those motion sensors on my leg. This is for the chronic knee pain program. And the sensors are automatically paired to the app, which you see on the left-hand side of the screen. Next slide, please. Oh, you can't? Shoot. Okay, yeah. All right, so now you'll see as I'm looking to start this exercise, which is a leg raise, I can easily see from the image on the app what that stretch should look like. And it's also gonna show me the target range of motion for this exercise. It's the little gray pie slice just below that image. Next slide, please. And you'll see as I start to move my leg up, you can see there that the sensors are capturing my actual movement for this exercise, tracking how I'm lifting my leg there. However, you can also see that I haven't quite reached that target range of motion that my physical therapist has set for this exercise. So the countdown timer for this repetition has not started yet. Next slide, please. And now as I lift a little bit higher, you'll see that I'm now in that green zone. I'm using the correct form and the correct positioning. That countdown timer has started, so it's gonna ask me to hold that position for a 5-second count. Next slide, please. All right, this is the next exercise. Very similar, so this is just a standard squat. You'll see again, it is tracking my movement, but I haven't quite reached that target green zone. Next slide, please. And now I'm using the correct form, the correct positioning. I'm in that green zone, the countdown timer has started. Now those are just a couple examples of the exercises. Typically it will take a member anywhere from 10 to 15 minutes to complete the daily playlist of exercises that have been prescribed to them. So very manageable for people to complete on their own schedule. And once they're completed, they're just gonna be asked to answer a few questions around their pain, how they're feeling, any feedback for the program so that we can continuously track their outcomes throughout, which we of course report back to you. Any questions there around the sensors, how they work with the app?
Questions? I have a quick one.
Yeah.
You say you have about 600 clients, employers.
Yeah, employer clients, yeah.
And so I could see it's novel, it's, it's like any technology, people want to start it. What is the percentage of people who continue it?
73% adherence from members that engage with the program.
Okay, that's a good number.
And just for context, we usually see anywhere between 4 and 7% of total members enrolling into the program. Yeah. Great question. Okay, so just a couple other pieces of technology we want to talk about here. You saw some of the screenshots of the app on those previous slides, but always like to highlight that to access any and all parts of the program, a member only needs one app on one single device. This is where they access their exercise therapy. This is where they have communication with their care team, do their video visits with their PT. Again, just single app, single experience. So very easy and convenient. Next slide, please. And then the last piece of technology, which we're really excited to talk about with employers, is called Enzo. So Enzo, I'm actually brought it here. You can see it, it's very small. This is a pain relief device that is available to members that might be in so much pain that they can't even do their exercise therapy. So this is an FDA cleared patented device. You can only get it through Hinge Health, which again, it's gonna use electrical nerve stimulation to provide pain relief. I'm not sure if anyone's had experience with TENS units. Very similar. The only difference here is that this is a wireless wearable. So the great part about this is you can see it there. It's really small. It fits underneath clothing. You can wear it while you're out doing your gardening. You can wear it while you're doing your exercise therapy. And always like to just think about, those individuals that might be taking Advil or even opioids on a daily basis because they don't have any other way to manage their pain. So when a PT believes it to be appropriate and the pain levels are, so high that they can't deal with their pain, we will send this to that member at no additional cost. Any questions there about Enzo?
Any questions? And at any time, so you're doing this and you're going by the instructions, but anytime you say that you can talk to somebody
if you have any questions, the way you're wearing it, if you have problems.
Absolutely, yeah. So you'll have the physical therapist and the health coach. They're both there side by side, and we're really great about being proactive about reaching out to you. If we haven't heard from anyone in a few days, our health coaches will reach out. How's it going? Are you, is your pain reducing? Any challenges? So they can certainly reach out, and we're very good about being proactive to reach out to them as well. All right, next slide, please. These are just some of the results that we're seeing from Enzo. So you can see it here, 2 times decrease in pain, 2 times improvement in walking, 3 times increase in mobility. So really great results. I mean, this is really life-changing for a lot of members that haven't found a way to relieve that pain previously. All right, next slide, please. Okay. So the last really pillar, going back to what we talked about earlier, is connected care. So we hear time and time again from employers that, as digital care becomes more and more relevant, they really want to start to bridge that gap between in-person providers and digital care vendors. So Hinge Connect is our platform that's allowing us to do that, and it does this by integrating health records and EMR data between our digital clinic and more than 750,000 in-person providers. So having access to this level of information, it's going to give our Hinge Health care team a more complete view of that member's history. We can proactively monitor orders in real time. If we see something, we flag, hey, this person might be going down that path to surgery. Should we step in, see if we can provide alternative, more conservative care before they go down that path? We can personalize and better coordinate those care plans, based on their specific history. So again, really looking just to bridge that gap that we see today, make a more connected view of each member. And we can skip past this slide, actually, time's sake. All right. So we talked about the member experience, we talked about technology, talked about our care team. Just wanted to share some of the outcomes that we're seeing. First, from an engagement perspective, to date, we've had over 301,000 members enroll into the program. On average, they are completing 56 exercise therapy sessions per member. I always like to point that out, right? Think about the impact of having a Mohave County employee, a Mohave County member completing 56 exercise therapy sessions and what that could do for their overall well-being. And again, I always like to point this out because, as you kind of alluded to, digital care, it's, it can sometimes seem like that shiny new object, but how often are people actually going to use it? I think this really shows that people that engage and enroll in the program, they're sticking with it. They're doing their exercise therapy because they're seeing results and they're seeing outcomes. Next slide, please. And with that engagement, the clinical outcomes follow. 62% increase in productivity with decreases in depression and anxiety, surgery interest, and of course, pain reduction. And with those outcomes, of course, the dollars follow. So on average, between $2,200 and $3,500 in reduced medical claims. And that's really primarily from being able to avoid, those injections, those potentially unneeded surgeries and procedures. Next slide, please. All right. So did want to highlight kind of a cherry on top here in terms of contracting. So we have been chosen and validated by over 35 health plan partners. We also have a very strong partner with Meritain. So I want to talk about what that means for Mohave County. Now, from a contracting perspective, this means that no direct contract is necessary. We simply handle all of that through the existing partnership with Mohave County and Meritain. So no contracting or legal process needed to review those. From a reporting and eligibility files standpoint, all the boring implementation stuff to get this program set up, that's already been handled between Hinge Health and Meritain, so relatively low to honestly no lift from the client side in terms of getting this program up and running. And then the last thing that I want to point out is we do have through this partnership 100% fees at risk ROI guarantee. So if you do not hit that 1.5x ROI after 1 year, 100% fees reimbursed to the client. Any questions there?
Any questions? That was a bomb at the end.
Save the best for last. Okay, so we put this together based on, with some help from Meritain, looking at your specific medical claims over the past 3 years to give you an idea of what pricing would look like on an annual basis. Now, one thing to keep in mind with our pricing model is that we are 100% utilization based. So you're only paying for those members that actually engage and enroll in the program. And even a step further, they don't have to just apply to be billed. They actually have to have that first interaction with their PT or health coach before we bill for them. So they could apply, they can get the kit in the mail. If they never open it, we don't count them as an engaged and enrolled member. So this here is really just giving you an idea of those estimated costs on an annual basis. It's based on our book of business on how many participants we typically see from the full population. Again, just to give you an idea of what that looks like. Of course, this isn't set in stone on how much it will cost. But you see our different programs here. The prevention program is free to the entire member base. The acute program, which is for those recent one-off injuries. I talked about that sprained ankle before. So maybe someone that's otherwise healthy, they don't have chronic pain, but they rolled their ankle and they want some support there. That's our acute program, $250 for 365 days access for that member enrolled in acute. For our chronic program, again, this is a big focus for us, those individuals that are typically the costliest. That is $995 per engaged member for 365 days of access. And then surgery is for those members that might need help with pre and post rehab. We have $0 there. We could probably work on this. It's technically $995, but we do cap our charges at $995 per participant. And the reason we have $0 is because for the most part, we're gonna recommend that they go through the chronic program before they engage with surgery. We feel that it is worth them going through 12 weeks of exercise therapy before they just go straight to the surgery table. Now, if it gets to the point, we know there are certain cases, surgery is needed, there's no additional charge for the surgery program with pre and post rehab. So I hope that kind of makes sense on the pricing there. But yeah, as you can see, we would project enrollment to be about 157 participants across all of these different programs, which would bring the annual cost to around $87,000. Now, on the bottom there, we're looking at forecasted savings. I mentioned we were able to look at some of the MSK claims over the past 3 years. And based on that, and based on our history in reduction in claims, that is the forecasted savings that we would see. So we're, looking based on our analysis at a 3.5x ROI. Any questions there?
Any questions? No.
Excellent. Okay, well, I just have, I think, one last slide for you, which is really just breaking down how we arrive at that ROI. There are a lot of numbers on the screen here. That top part of the slide is really what we walk through in terms of estimated costs of the program. And on the bottom is where we're starting to look at your actual medical spend, your actual MSK spend. Now you can see there, MSK again makes up about 14% of total annual medical spend, around $1.1 million on average over the past 3 years in MSK claims. Now, we obviously can't impact every MSK dollar, right? There's catastrophic injuries, there's car accidents, those are reported as MSK claims. And we can't, prevent those injuries from happening. We can, however, impact a really great deal of MSK spend, mostly being driven by those members with chronic conditions. So it's those high cost claimants that are disproportionately driving a bulk of your MSK spend. And those are the ones that we're really gonna focus on to recruit into our programs. Now, Mohave County did nothing today or in the coming years, we would expect, as we've seen over the past 3 years, that MSK spend to remain pretty consistent over time. But by putting in, a conservative care program like Hinge Health, we've shown the ability to help our employers save about 50% in spend from those costly MSK services. So that's how we arrive, a long way on how we arrive to the projected annual savings and a 3.5x ROI. It's a lot of numbers. I completely realize that, but just like to break it down on how we approach looking at savings.
Thank you.
Yeah.
I have a question.
Yeah.
Let's take me, for example. Okay. I'm starting to have hip issues. Bad. So I would enroll in the acute. Is that it? So how would I get started?
Yeah, so you would go through the clinical screener. That's we are gonna place you in the program that we feel is appropriate.
So I go through the screener, they send me this thing, I sign up for it. But let's say your program works so good that in 30 days, I have no more pain. So am I still charged for that period of time, or can I leave it at any time?
So our recommendation is 12 weeks. People will start feeling better after just a couple of weeks. Our health coaches are going to encourage you to continue to do your exercise therapy because, we always say movement is medicine. You need to keep doing this over time and build up, back to lifestyle modifications, right? You need to build up, that understanding that this is helping me with that pain. I need to remain active. With that being said, it actually brings up a good point. In the partnership with Meritain, we do have milestone billing. Mm-hmm. And what that means is, and it's only available through health plan partners like Meritain. So that chronic program is actually split out into 3 separate charges. That first charge is $695. So once that member gets their kit, they start their exercise therapy. The second charge is $150. That's after 30 days and they've engaged with 4 exercise therapy sessions. So that's our metric to show that they're still engaged in using the program. And then the last $150 charge is after 60 days and they've done 8 exercise therapy sessions.
Okay.
Yeah.
Okay.
And I can write that out and send it up in a recap if needed.
Because I also need memory. Do you have exercises for that?
I do too. I can't help you there, unfortunately.
All right. Any other questions? Nothing? Well, thank you very much.
Yeah, thank you. It's great to be here. Thank you.
Okay. Next up, we have illness, hospital indemnity.
Hello? Can you all hear me?
Yeah, Lana, we can barely hear you.
Okay,
good morning, everybody. Can you hear me okay, Erin?
Yeah, that's better.
Okay, great. Good morning, or good afternoon, I should say, Madam Chair and trustees. It's great to meet you all. My name is Alana Scher. I work on Erin's team to help with all things voluntary benefits. So that's what we'll be talking about today. I'm going to go ahead and share my screen. So Erin, I'll have you let me know if that is not working. And you should be seeing it now. Can you all see that okay? Okay, great. So I will jump right in here just to kind of start with a quick overview of how we look at voluntary benefits from a strategic perspective. So just like Erin and Amanda and Missy work on your core benefits, we also take a look at voluntary benefits from a really holistic perspective. And so what that means is while the products themselves absolutely have inherent value, we also find it very important to consider things like the communication and enrollment strategy, the technology, how is it going to integrate with the system, the Ben admin system, The product selection itself, of course, looking at how are the contracts arranged, negotiating the best contracting language that we can, and then picking the right carrier partner and ensuring that we're leveraging any efficiencies, both administratively as well as from a cost perspective on the carrier side. So these are all the things that we take into consideration when implementing a voluntary benefits program. So next, we just wanted to share a little bit around trends that we're seeing in the voluntary benefits landscape overall. So really, first and foremost, wanted to share a little bit about what we're seeing in terms of why are employers and employees even interested in these products. And so the products that we're going to talk about today, the accident, critical illness, and hospital indemnity plans are all designed to provide employees with cash benefits if they have any covered accidents, illnesses, or hospitalizations. And so really the primary focus is to provide employees with additional financial protection to help them offset some of those out-of-pocket expenses that they might incur when utilizing their health plan. It's also a really nice way to provide employees with some extra cash to put towards things that traditional insurance may not cover. So for example, if an employee is gone through a really tough accident, or maybe they have a very severe illness diagnosis that they're facing and they need to fly in family members, or they need to order in their meals because they're unable to cook at the moment. These are all things that they can put those dollars towards, but overall in alignment with that idea of providing employees with some enhanced financial protection. We've also seen employees have a larger interest in more lifestyle benefits to help address some of that work-life balance. And so these are benefits that can help incentivize some of that through those cash benefits. Additionally, we know that all employers are dealing with turnover and struggles around recruitment and retention in the current job market. So from a benchmarking perspective, these products are ways to maintain competitive as well as address employees' expectations, most of which expect these products to be offered when they're looking at different employment opportunities. So it's just a nice way to differentiate yourself with potential candidates. And then lastly, like I mentioned on the previous slide, we're always looking at ways to address cost. And so in order to do so, we'll look at A, are these benefits competitive for the employees, but B, how can we leverage the voluntary benefits to achieve savings on the employer side as well? And I'll dig into that a little bit more. We have some savings to show today based on the options that we received. The other trend that I'll touch on very briefly is just a shift from individual to group products. So some of you may be familiar with AFLAC, the Duck, that's a pretty popular one. Colonial, Transamerica, these are all voluntary benefit carriers who offer individual products. And what we've been seeing is more employers shifting over to the group market. There are a few reasons for that. The first is they offer better benefits. So they will waive things like pre-existing condition limitations, waiting periods. They'll ensure that employees never need to go through evidence of insurability or answer any health questions in order to be eligible for coverage. And they're also pretty adaptable to our current landscape. So one example of that is in response to the COVID-19 pandemic, many of our group carrier partners started adding COVID-19 as well as mental health coverage to their plans to align with what was happening in the world. There's also some benefits around cost effectiveness on the group product side. We typically see somewhere between 30 and 50% savings on the premiums for the employees, as well as potential bundling discounts on the employer side if you're pairing an employer paid benefit with a voluntary benefit under the same carrier. And then lastly, there's just more administrative ease with these group products. So they're able to be built on Ben admin systems. It's one line of, or one plan per line of coverage as opposed to many different plans. It allows for more streamlined communication and overall a better claims and service experience for employees. So all of that is to say, we did do some marketing for you all. And what I've put together here is kind of a high-level marketing overview. If you at any point want to go line by line and in depth, we did include those in the materials as well. I'm happy to do that and answer any questions on those. But in the interest of time, just wanted to provide a high-level overview of what we found in our marketing. So just so that you're aware, under carrier considerations, you'll see the things that we typically pay attention to when we're putting together our recommendation. So we're going to look at plan richness and how competitive are the rates. Can the carrier and the plans integrate with the technology? And are there any subsidies we can provide to offset the cost of building the plans on the system, getting file feeds set up? Is there any bundling discount availability with existing carrier relationships? And lastly, what is that employee experience going to be? So based on all of that, looking at our marketing results, our recommended carrier is going to be Aetna, and that is for a couple of reasons. So the first is they provided the richest plan design with some of the highest benefit payouts at a very competitive cost. So some examples of that is they were able to waive all pre-existing condition limitations and waiting periods. They were also able to offer perpetual guarantee issue, which just means that the employees will not have to answer any medical questions to be eligible for coverage. And they also included COVID-19 as a covered benefit. In addition, they are able to provide some employer savings on the Meritain administrative service fees. So because of the partnership between Aetna and Meritain, if you are to offer the voluntary benefits through Aetna, they can include a 50-cent per employee per month credit per product. So if you were to offer all three, the accident, critical illness, and hospital indemnity, that's a total of $1.50 savings per employee per month on the Meritain administrative fees. They were also able to provide a $1,500 technology credit per line of coverage, which again is going to help to offset the build or any EDI feed setup costs on the Munis system. And then lastly, and probably most importantly, is what's the employee experience going to be? So because of the Aetna Meritain partnership, Aetna is actually able to scan through the claims data and then proactively reach out to employees when they see a claim come through that may apply to one of the voluntary benefits. So it's a really nice way to ensure that employees remember they have these plans, especially when they're going through something traumatic. We don't find that employees tend to remember that they have these plans. So it's a really nice way to ensure that they're actually getting the most out of these plans from a claims perspective. So overall, Aetna came back as the strongest option and the one we would recommend if you were to proceed with offering these plans in the coming year. And then lastly, I just wanted to touch on an additional resource that can be made available to you all through the offering of the voluntary benefit plans. So just like your other plans, the voluntary benefits do include commissions. And so what we're able to do is reinvest those dollars into paying for essentially a communication support during open enrollment. And what that consists of is access for employees to meet one-on-one with benefit counselors who are trained on all of the benefits that the trust offers. So medical, dental, vision, life and disability, the new voluntary plans. And they're able to answer any questions that they have, help them talk through their options, and figure out what might be the best fit for them for this upcoming plan year. And then they will actually enroll them in real time during that one-on-one meeting. And those meetings can be done either virtually, in person, or a combo of the two. So it's just a nice way to provide employees with some added one-on-one support during open enrollment. And I will mention too, the educators that the employees would be meeting with are not commissioned. They're actually salaried employees paid on a per diem W-2, so they're not incentivized to sell. Really, they're evaluated on how well do they educate your employees. So wanted to share that with you. It's a nice resource that actually Erin and I are working on with another group. It's a way to kind of take some of the lift off of your team during open enrollment, which I know can be quite a lot at times. So wanted to make sure that we shared that as a resource available to you all. So I'm going to pause. I know I just talked pretty quickly and shared a lot of information. So Madam Chair, I'll open it up for any questions.
Is there any questions? Yes, Susie.
Okay, this proposal only covers three things, right? On page 289 of the book, it also added two other stuff there, long-term disability insurance and permanent life insurance. Those two are not included in this proposal, correct?
So yes, and that's a good clarification. We did receive proposals for those products. But typically, it's a best practice in the first year of rolling out these plans that you focus on just 3, really max, so as not to overwhelm the employees and really ensure that we can do thorough education on the first 3 that are being offered. We did grab proposals for the other 2, and absolutely happy to discuss them, but our recommendation would just be, from a benchmarking perspective, to focus first on the accident, critical illness, and hospital indemnity.
Okay, thank you.
Any other questions? Okay. Hey, thank you very much.
Thank you, everyone.
Okay, our last before lunch. Now, what happened to the executive session?
Madam Chair, we held the executive session. I had to double check with Tyler to make sure we could do it, that we are posted correctly. We can do it after this presentation, or we can do it before, however you want to do it.
Okay, let's do this presentation, then do it, and then break so they can get, you know, because they have to get back the technology anyway.
Thank you.
Okay. Okay, so up we have the vision, and that's you.
Hello, everybody. Can you hear me?
Oh. Your name?
Hi, my name is Kelly Olala, and I'm presenting on behalf of IMED Vision Care. We're your vision carrier.
Okay.
Okay, I'm going to go ahead and share my screen. And we're going to go over just a couple of options that we've been talking with Aaron and Amanda about. So let me pull this up. This is just a spreadsheet that I created, so it's not a pretty PowerPoint, but I think it'll be an easy way for you to understand what I'm trying to talk about here. But my main focus is to talk about premium progressives. Can you guys hear me okay, or am I? Oh, sorry. Hold on. Let me share my screen again. Now, can you see it? Okay. Can you see that screen there? Can you see my spreadsheet?
Yes, they're communicating through the chat box. They can see it.
Oh, thank you. Thank you so much. Okay, so my focus, what I really want to talk about, and I'll be really quick, is honestly just moving your network. Right now, you guys are on the Select network, which is a really excellent, robust network. However, our focus for IMED has recently, over the last several years, has been the in-state network. And the difference is, let me explain. Select network just offers an allowance on your premium progressives. Okay, on the Insight network, we are able to offer a premium progressives at a fixed rate. So the premium progressives are your most expensive lenses. They're your old bifocal lenses. So if you're a single vision wearer, you're eventually going to move into the premium progressives. So that is what we're seeing with your utilization over the last several years. We've seen an increase in the progressive. So what we're worried about is the experience for the members out of pocket once they're at the point of sale. That is going to increase over the years just due to the economy and just the price of things going up. So currently what we're offering, though, you guys have a $90 copay with $120 allowance, and then 20% off of the remaining balance. However, if we were to move you to the Insight network, we could do that, and you guys would actually have fixed, you would have fixed cost on your progressive lenses. They would range anywhere from $110 up to $200, with your most popular falling at around the $200 range for your progressive lenses. So the savings is right below here. This shows you just a little bit about what I'm talking about. So currently, this is your plan design, and I'm using $350 as your average retail. And you can see by the time we equal everything out, you're paying about $250 member out of pocket. However, if you take that same tier 2 lens, and Insight network, you'd be paying $130. That would be your fixed cost. There's no allowance. There's no, I'm guessing the only things you can add to that would be options like anti-reflective coating, scratch coating, things like that would increase your out of pocket, but you would at least know going in that you're going to pay $130 for a progressive lenses in a tier 2. You're going to pay $145 in a tier 3. So these are fixed costs, and that's what your Insight network can offer versus what you're on currently, which is Select. Okay, that is your big difference. That's really about it. It does come with some impact to your premiums. It's also going to be the network where we can offer you additional programs on top of what you're getting right now. So, sorry about that. But that would be your only change, would be to the progressives. Everything else would remain the same. So your single vision lenses would still, be the exact same as what your members are enjoying now. There was also some talk about adding a new frequency every year for frames. Currently, you guys, Mohave is on a 12-12-24, meaning you get a new frame every other year. However, what seems to be most popular now when we're selling a plan is a 12-12-12, meaning that you can get a new frame every year, which is really nice if you're, buying a new frame every year for your ophthalmic, and then you can also buy a prescription the following year. So you don't have to use the same frame. You can actually buy a new frame every year. So that was another enhancement that we discussed. So really, the big changes I would suggest based on your utilization are your, frequency. I think that's a nice enhancement. Most groups love to get the new frame every year. And then secondly would be the move from Select to Insight. The disruption was minimal. When I ran the disruption report from July 2020 to current, there would only be 4 claims that were disrupted, a total of 3 providers. So the disruption's very minimal, or else I would have never suggested it. But I do think there's some really good savings there on your progressive lenses, and I do think you're going to really notice a difference at your member point of sale. So those were my, really what I wanted to get across, my points here.
Okay, any questions?
I have a question.
Yes.
Just a clarification from the packet that we have. There are several proposed benefits. Which one are we looking at in terms of the proposal? Because the monthly rates are different.
We looked at 4, Madam Chair and Trustee Duranzo. We looked at 4, and what we really came back to is the second one, which is really kind of a tweak in there, and it's the one that what Kelly's talking about. What it does is really for less than $1 on the employee, a little over $1, I think it does on the family. What it does, it breaks out for those people that are buying more expensive glasses. It gives them a higher benefit, and it also gives them a greater frequency. So instead of a 12-12-12, it's 12-12-12-24, it's 12-12-12.
Is that the buy-up, the option
We just switch everybody. This is 100% employee paid, and so it would go from the lower plan to the higher one. And and I think it's worth considering because of that particular, more people are having more expensive glasses. It just gives them a better benefit.
So basically you're presenting different plans that they could choose from.
Yeah, we looked at 4, but we threw the other ones out because if you look at the premium costs on them, they're just massive, and we frankly didn't think anybody would buy them. We just said switch everybody over. It'll give them a higher benefit on the ones who really, the big
So which one of this is the one you're presenting then?
Yeah, exactly. The second one.
The second one? What page are we looking at? Because they have different premiums.
I'll tell you what, the one you want to look at is one that says Insight Buy-Up. However, it's not exact.
What's the page?
What page?
302, 303.
See what happened. Kelly, what happened is the plan, I'll clarify this in between because the plan markers didn't come through on the copies.
Okay.
So that's the problem.
Yeah, I think it's
Like Aaron
305 too.
Considered doing a base and a buy-up plan, but we determined that we didn't think, you guys already have a really nice enhanced plan. You have a $65 frame allowance. That's really the base plan. That's That's an enhanced plan. So instead, we thought of adding to that plan, adding 12 frequency.
It's actually the plan on page 303 is the one we're recommending.
303?
303.
Not 305? Oh,
I thought it's 305.
I know, now I want 305.
So it's 303, it's inside, option
the
one
current-
inside?
The one that we're currently on is 299. It's on page 299.
Okay. This is what we're currently, so it's not proposed benefits, that's where we are, 299, right?
299. Well,
Yeah, and the reason we're recommending 303 was because of it's lower premium cost.
Yeah,
That's correct.
305.
You're right. So it is, correct. So this one, this is the one, and I apologize.
It doubles the subscriber cost.
Well, if we do, we don't recommend, we're not recommending 303 because it basically doubles the premium.
Wait,
So we're at
I'm sorry,
305 then?
305? I think we got the wrong ones.
Too many page numbers going around. I apologize. We're currently on 299,
Right.
and we're looking at the one on.
That's on me, Aaron. I think I provided you guys with 4 different proposals. And honestly, in the end, we're ending up with one of those proposals, but that doesn't match.
Yeah, but which one?
Because
What is the subscriber for the one you're recommending?
the one we're recommending has a $6.43.
Oh, okay, so that is 303.
Okay, thank you. But to that, we also,
Okay.
Okay.
that's the one we're recommending, but keep in mind that is a 12-12-24 frequency.
Okay.
The proposal you don't have in front of you that I would need to get you is that exact same plan, but it would have a 12-12-12 frequency.
So she's saying the proposal is not in front of us?
So no, it is. It's just, it's the confusion on the page numbers is what's doing it. Because it's what she's correct, and what Leanne was pointing out correctly, is that the lower cost when the frames are still at the 24 months instead of the 12s.
Right.
Right, so you still would have to wait 24 months to do
Which
frames.
one is going to give us the 12 months?
That's 305.
305, and
That's the one that
double
essentially
double the
premium is
subscriber.
People aren't going to buy it. It's going to, I think that's too dramatic of a change in premiums.
It is a lot.
So
Plus, I
right
don't
here,
think
what they're
you need
getting
that
is they're getting a fixed cost by doing this. What they're doing is they're getting a fixed cost for those higher grade additions. So they're going to pay less out of pocket. And it's if they're actually buying the progressives and the anti-reflective coatings, which frankly, most of them are.
Yeah.
I think that tweak to the benefit is worth the small increase in the cost. That's why we threw it in. But I think when you get into the other ones, the additional premium cost people just start dropping it.
Yeah. It's double.
I can say you're really looking at like $7.31.
You're paying for it. You're paying for the frame anyway. Okay. Well, thank you very much. I think we figured that one out.
Apologies, Madam Chairman.
No, that's right.
Yeah, I apologize.
That's okay. All right. Thank you so much. Is there anything else? No? Because we're going to move on. And we have now the executive session coming up.
Yeah, Madam Chair, we do. So at this point, we'll need to basically excuse everybody from that does not need to be in. We'll do the executive session.
Right. And then after this, we have lunch. So you're not going to have to come back right away. Sure, right?
Correct.
Okay. Okay, so anyone who doesn't have to be here, skedaddle.
And lunch is set up upstairs, so you guys are welcome to go up. And IT, if you'll just give us a thumbs up when we're ready.
Right.